All right, so oxygenation. So our objectives are, we have a lot. We're going to identify the basic structures and functions of our respiratory system. We're going to identify factors that affect our gas exchange. We're going to discuss the common diagnostic tests that we use to evaluate alterations in the respiratory system. We're going to describe components of a complete respiratory assessment, describe the medical management of clients with respiratory disorders, describe the terms associated with respiratory insufficiency, describe gerontologic considerations in the assessment of the respiratory system, discuss major risk factors in the patient's history that could affect oxygenation, identify changes across the lifespan of a patient that could affect oxygenation, identify cultural and spiritual considerations that could influence optimal oxygenation, recognize priorities regarding acute complications associated with oxygenation disorders, utilize the nursing process to develop a plan of care for patients with dysfunction in their oxygenation status, identify the priority nursing diagnosis most appropriate for a patient with oxygenation dysfunction, utilize health promotion activities to decrease the incidence of oxygenation dysfunction. Identify community-based healthcare resources to help assist a patient that requires support to meet oxygenation needs. Differentiate between the pathophysiology of oxygenation exemplars. Describe complementary and alternative medicine agents that can influence oxygenation. Describe nursing interventions using evidence-based practice that promote oxygenation. Discuss the collaborative modes of therapy and the nursing management of patients with oxygenation dysfunction. Apply essential pharmacological principles to the management of patients with oxygenation dysfunction. Assist the patient with oxygenation dysfunction to identify specific learning needs related to promoting self-management, demonstrate proper procedures for the use of appropriate equipment for patients with oxygenation dysfunction. So talking about the pulse oximetry, oxygenation delivery devices, oxygen flow meters and central spirometers, chest drainage systems, tracheostomies and suctioning. Describe procedures for safe and accurate oxygen administration. And lastly, evaluate the effectiveness of nursing care in patients with oxygenation dysfunction. So
That's enough for me. I'll see you next week.
Right, time to go now. We're all overwhelmed. All right, so what is oxygenation? Oxygenation is just the process in our body that helps maintain oxygen levels that are necessary for the survival of all the cells in our body. The respiratory system provides oxygen for cellular metabolic needs, and then it's going to remove that carbon dioxide. Carbon dioxide is a waste product of cellular metabolism. There are a variety of different respiratory disorders that patients can present with. They range from mild to life-threatening. So we are just going to do a review over the next couple of slides of our anatomy. So we have our upper airway, our paranasal sinuses, the lower airway, and the epiglottis. So in our upper airway, we have our nose, our sinuses, and our pharynx. Under those three categories, we also have our nasopharynx, our oropharynx, and our laryngeal, and we have our larynx, which is our voice box. Under our perineal sinuses, we have our frontal, ethmoidal, sphenoidal, and maxillary sinuses. Our lower airway is going to include our trachea, the bronchi, the bronchioles, our lungs, and our alveoli. And then our epiglottis, that's that little flap of cartilage that covers the opening of the larynx when we swallow to protect any food from going down there. So our accessory structure, so this, we're gonna have our diaphragm. This is gonna separate our thoracic and our abdominal cavities. During inspiration, the diaphragm is gonna contract and move downward, enlarging that thoracic space. We We have our mediastinum, which is that wall that divides the thoracic cavity into two halves. The pleura is that sac-like serous membrane. Our visceral pleura is the surface that covers the lung, and then that parietal pleura covers our chest wall. And then we have that serous fluid that lubricates the visceral and the parietal pleura so that they don't rub together. So what is the main function of our respiratory system? The main function is for us to be able to exchange oxygen and carbon dioxide between the atmospheric air and the blood and between our blood and our cells. So the definition of ventilation is just the movement of air into and out of the lungs, but it does have to be sufficient enough to maintain normal arterial oxygen and carbon dioxide tensions. It's the actual movement of air in and out of our respiratory tract. Every time we breathe in, every time we exhale. Air must go into all the way down into where our alveoli are in order for us to be able to see that good gas exchange between the oxygen and the carbon dioxide. What are the mechanics of our ventilation? We have inspiration, expiration, diffusion, perfusion, and distribution. So inspiration is that movement of oxygen into the lungs when we take a deep breath in, inspiration. Expiration is when we breathe out and we're removing all the carbon dioxide from our lungs. Diffusion is the transfer of a substance from an area of higher concentration or pressure to an area of lower concentration or pressure. It's the exchange of oxygen and carbon dioxide across that alveolar area. Perfusion is the flow of blood in the pulmonary circulation that goes all around our body and perfuses all of our organs, delivers all that oxygen-rich blood. And then distribution is the delivery of that atmospheric air to the separate gas exchange units in the lungs. So when we talk about alveolar respiration, alveolar respiration is going to determine the amount of carbon dioxide that we have in our body. So if we have increased carbon dioxide primarily in our body fluids as carbonic acid, it causes our pH to decrease. So it's going to go below 7.4. Decreased carbon dioxide causes pH to increase above 7.4. Our kidneys are going to excrete that excess hydrogen ions, which keep that serum bicarbonate levels near normal. Remember, this process takes a little bit longer than our lungs. Our lungs, they're both going to start working at the same time, but the lungs are going to help correct everything a little bit quicker. It takes a couple of days for the kidneys to be able to adjust everything. Lungs eliminate the carbonic acid by blowing off more CO2 or conserving CO2 by slowing down our respiration volume and reabsorbing the bicarb. The kidneys excrete more bicarb, and then disturbances in pH that involve the lungs are considered respiratory. So anything that involves the lungs is going to consider respiratory. Disturbances in pH that involve other mechanisms are termed metabolic. At times, there can be respiratory and metabolic disturbances that coexist together. So this stuff should make sense to you because we just learned all about ABGs. All right, so transport of gases. So oxygen transport occurs in our body in two ways. We have a very small amount that's dissolved in water that's in our plasma. The greater portion of oxygen combines with our hemoglobin in our red blood cells. It's our oxyhemoglobin. The CO diffuses from the tissue cells to the blood. Those bicarbonate ions are then transported to the lungs for excretion. We do have those imbalances that we've been talking about. So we have respiratory acidosis, which is when the kidneys retain more bicarb to raise the pH. Respiratory alkalosis, which is where the kidneys excrete more to lower the pH. Metabolic acidosis, the lungs are blowing off oxygen to raise the pH. And then metabolic alkalosis, the lungs are retaining carbon dioxide to lower the pH. Pulmonary perfusion. So our perfusion is the blood supply to the lungs through which our lungs are going to receive nutrients and oxygen. We have two methods of perfusion. So we have bronchial circulation and pulmonary circulation. Bronchial circulation is the bronchial arteries, which supply blood to the trachea and our bronchi. Our pulmonary circulation is going to be our pulmonary artery transporting that venous blood from the right ventricle into the lungs. Clients with lung and cardiovascular diseases probably will have decreased pulmonary perfusion. So in patients that have respiratory issues, you might hear the doctors ordering certain tests. They might order a ventilation perfusion scan. You might hear them talking about a ventilation perfusion ratio. So this test is going to, it's an indicator of cardiopulmonary status, and we call it a VQ ratio. So it indicates the effectiveness of airflow within the alveoli, which is our ventilation. It also determines the adequacy of gas exchange within those pulmonary capillaries, which is our perfusion. You can look in your book on page 286, figure 19.4 is going to talk more in depth about normal and abnormal ratios and what that could look like and mean for our patients. So what are some problems that we might see in respiratory physiology? So our respiratory system usually has a sufficient amount of reserves to help maintain that normal equilibrium or homeostasis in our blood during times of stress or sickness, disease. Respiratory insufficiency will develop if there's too much interference with ventilation, diffusion, or perfusion. It can't compensate for it. So we might see hypoxia. So hypoxia is a decrease in the oxygen in the air that we breathe in. Hypoxemia is a decrease in oxygen in the blood. So you guys need to know the difference, okay? Hypercapnia is an increased carbon dioxide level in our blood, and hypocapnia is decreased carbon dioxide in the blood. So some of the primary factors that we might see patients that have airway resistance. So sometimes resistance is going to be related to the diameter of their airway. It could be the rate that they're getting air in, and it could be the speed of the gas flow. There's a lot of different things that contribute to these airway issues. As the rate of our breathing increases, so does our resistance. They both go up together. A narrow airway resulting from increased or thick mucus. So our patients that have pneumonia, our patients that aren't moving, who don't have a lot of muscles, don't have good cough reflexes, they can't get that mucus up, and it's all just sitting there. Some patients who have asthma, they have these bronchospasms, even patients with edema. So some of the conditions that can alter that bronchial diameter that we were talking about in the airway, we have asthma. In asthma, it is a contraction of that bronchial smooth muscle, so that can make that diameter a lot smaller. Patients with chronic bronchitis, this is a thickening of the bronchial mucosa, and it always stays that way. We do give them medicine to help with some of those symptoms, but for the most part, they always have that thickening of that mucosa. So if the mucosa is coated all on that bronchial area, that's also going to make that diameter small. And patients that have COPD, they have chronic bronchitis a lot. And then patients that have emphysema. So patients that have emphysema lose the lung elasticity and that inability to get air out. Some patients have issues with what we call lung compliance. So this is a decrease in surfactant in our lungs. Some patients have fibrosis. They can have scars in their lungs. They might have cystic fibrosis, which is, a whole bunch of mucus. We can have patients that have edema. Even atelectasis. So when we talk about atelectasis, you guys will see this a lot in the med-surg setting. This is what you want to prevent when patients have surgery. Just your normal patients come in and they're sick, they're not moving around. All those little alveoli, they collapse. They look like those little trees. There are the little balls on the ends of the trees. They collapse, they get, kind of like smashed down, and then fluid gets in there. It's a very dark environment. It's a very moist environment. It's the perfect breeding area for infection. So all that fluid weighs down the alveolar, and then they can't pop open. When they pop open, that's when we get that good oxygen in. But in atelectasis, they collapse. So when we tell them to do their incentive spirometer, we're helping to keep that from occurring. So those issues are going to affect lung compliance. And then when our lungs are stiff, we are going to require a greater pressure gradient because there's no give, because they're so stiff. So we always know with whatever we're talking about, there's always a developmental consideration. So with infants, compared to adults, their airways are very short. Their chest is very small, and aspiration is a real problem for them because that airway, it's such a small area. So aspiration is an issue for them. Respiratory rates in infants are very, very much higher than in adults. As they get older and that alveoli numbers increase, so they increase in number and they also increase in size. As that starts to happen, more adequate oxygenation is accomplished, and then in turn, you'll see that lower respiratory rate. An infant born before 34 weeks has a decreased surfactant. This can lead to collapse of that alveoli and poor alveolar exchange. So that's why they try and keep them in as long as they can. If they think that they can't keep them in there, then they have to give them medicine to help them speed up that process of those lungs developing and making more of that surfactant so that they will be able to breathe when they come out. Then we have our toddlers, our preschoolers, our school-age children and adolescents. So preschool children, their eustachian tubes, which is back in their ears, their bronchi and their bronchioles are more elongated and they're less angular. This can affect fluid. They can be more susceptible to ear infections. They can develop bronchitis, pneumonia, and asthma. Mainly, some of this is due to the fluid in the ears, and then a lot of this can be caused by secondhand smoke. So you want to do a lot of education if you're working with those babies and they have parents that smoke. So this is a picture of a normal airway on the left. You can see the huge diameter. If you go over to the middle, this is an asthmatic airway. So you can see that those walls are inflamed and they're getting very thick. This smooth muscle back here is starting to relax, and you can see the change in the alveoli. So in the very last one, this is an asthmatic airway during an attack. You can see how tight those muscles are getting. You can see all that air that's trapped in the alveoli. They all look like little blown up balloons, and how inflamed and thickened the airway is. That picture is in your book if you guys want to look at that. So we know aging has an effect on everything. So tissue and airways of the respiratory tract are going to become less elastic. Everything loses their elasticity. So even your tissue and your airways. The power of the respiratory and the abdominal muscles is reduced. So for them to really be able to have good use of their diaphragm, it doesn't happen. It's much less efficient than it is when we're younger. It's much more easy for their airways to collapse. There is different immunological considerations to think about as they get older. We see a decrease in their lung compliance. We see a decrease in their vital capacity. We're going to talk a little bit more about that in a couple more slides. We see a decrease in the secretion of mucus. We see an increase in their residual volume. Some patients experience changes in their chest where it's unable to stretch. Patients develop osteoporosis, get more of a cough, and then all of these combined with a possibility of a lifetime exposure to pollutants depending on where they lived or what kind of work they did they smoke cigarettes? So it's kind of like a combination of things. Medication considerations, they also affect our oxygenation. So we know that opioids depress our respiratory center. So sometimes it's the medicines we give or the medicines that people take. It's going to decrease the rate and the depth of respirations. So we always want to be, whenever, we've talked about this before, but I'm going to say it again because it's that important. Whenever we are giving narcotics or any type of a sedative or multiple things together that could have a sedative effect, we want to be alert for the possibility of respiratory depression or arrest. So we want to be checking those respirations before we give things, check them after we give them, and keep on monitoring these patients. We also have environmental considerations. So there has been research demonstrated that shows a very high correlation between air pollution and cancer and lung disease. There are occupational exposures, so people who work and they deal with asbestos for a living, if they deal with silica, coal dust, if they worked in the coal mine, these are all things that can lead to chronic pulmonary disease. And then people who have been exposed to chronic radon, any kind of radiation, asbestos, and arsenic, they can all lead to lung cancer. And then we have psychological health considerations also that can affect our oxygenation. So people respond, we know when they get stressed, they may sigh excessively, or they may even hyperventilate depending on how bad the issue is. So this, as we learned when we were talking about our metabolic issues or our respiratory issues, can lead to a lowered level or arterial actually that's a misspell, of arterial carbon dioxide. So lifestyle considerations. So sedentary activity patterns do not help encourage the expansion of the alveoli and the development of pulmonary exercise patterns, so deep breathing. So exercise is good for everything. We want to encourage our patients to exercise at least 3 to 5 days a week for 30 minutes a day. Regular physical exercise is going to improve heart and lung fitness, and it's going to reduce the risk of heart disease. Cigarette smoking, active or passive, so either they're smoking or they live in a house with someone who smokes, is a major contributor to lung disease, respiratory distress, and lung cancer. So it's important that we assess our patients to see if they're smoking and then educate them about possibly quitting. If you do have a patient that is a smoker, you want to further investigate. So you want to tell them first and foremost that cigarette smoking is the most important risk factor for developing COPD. You want to inquire about how many cigarettes do they have a day? How many packs do you think they smoke a week? How long have they been smoking? And if they said they quit, how long ago did they quit? Find out who in the house smokes. If there's ever been any related illnesses to any type of lung issue. So did they have any mother or father or grandparents, brothers, sisters that had any type of a lung cancer? Or if they smoked, did they grow up in a house with people that smoke, even if they don't smoke? These are the things that we want to ask. All right, so we can see a lot of medical problems related to smoking. So we can have cardiovascular issues. So the raise in that carbon monoxide level in the blood causes constriction of our peripheral blood vessels. When our peripheral blood vessels constrict, that's what's going to contribute to cardiovascular disease. It's going to cause hypertension, and it's just going to snowball from there. It can cause lung disease. So tobacco smoke disrupts all the structure of them alveoli. They cause them to be very overstretched and inelastic. So in emphysema. So they're going to hold on to all this air and they're not going to be able to get rid of it. Cancers, smoke from inhaled tobacco products contains more than 40 carcinogenic chemicals. So we can see cancers from people who primary smoke cigarettes, or cancers can develop in people that just live with people who smoke. They can get that secondhand smoke. It also causes gastrointestinal disease. It can cause the recurrence of gastric ulcers. And then it can also cause low birth weight babies. So if you want to talk to your patient about quitting smoking, you want to first assess the patient. So while you're talking to them, you want to be able to assess their readiness to learn. If it's not something that they're willing to do, if they're not going to want to quit, they're not going to learn. They're not going to listen to you. It's just going to be a waste of your time. So really talk to them, educate them, find out if they're ready to learn, find out if they want to do it now. Is it something they're going to pursue when they go home? Do they want resources to start? Once they get into the community, maybe they want to start now. Maybe usually when you see patients in the med-surg setting and they have been diagnosed with lung cancer or they see some type of a tumor and they're waiting for a biopsy, they all quit while they're in the hospital. So they might want to quit when they're in the hospital. You can give them a nicotine patch. So just try and assess their readiness to learn. And then if they are ready to learn, then you want to develop a plan of care. So you want to find out for them what type of tools might be helpful for them to be successful. So maybe they need nicotine gum. Maybe they need a patch. Maybe some people can just quit cold turkey. It just depends on what they think is going to help them. We also know that patients that quit smoking, it's a very high probability that they're going to gain weight because they will start eating things. They're going to eat more to fill that void of not being able to smoke cigarettes. So we want to do things that will encourage them to develop gaining weight. So we can encourage them to change their diet, increase their physical activity. So even if they are eating a little bit more, maybe they won't notice it because they're exercising. And then of course there is treatment that we can give them. So we can give them bupropion or Zyban. We can give them Chantix. And we can give them the nicotine patch or gum. So Chantix is something that I've always heard mixed reviews about. I've heard people say that they absolutely love it and that they were very successful and it helped them. I heard people say that it caused them to do weird things, that they drove their car, they ended up naked on their front lawn and woke up at like really bizarre things. So I've heard success stories and I've heard people that say they would never take it again. So it's just a person's, their own choice. So we want to provide counseling for them. We want to tell them, we want to educate them about the risks of smoking, what it can do to them. We also want to tell them the things that will be the good side of quitting. How they're going to be able to taste food again. They're adding years of their life on. Their lungs can recover depending on how long they've been smoking and how old they are. There's outpatient programs that we can recommend to them. There's even support groups that they can go to. There's hypnotic therapy you can go to. And then we also want to tell them about possible withdrawal side effects. So they can be cranky, they can have headaches, they can be nauseated, they can be shaky. So these are things that we want them to be prepared for, because if they don't know that it's going to happen, then they're just probably going to quit and say this, I don't know what this is. I don't want to feel like this. I'm not doing this again. But if they know that it's coming and they know that it's just a small, period of time that they're going to experience these symptoms and it's expected, then hopefully they will stick with quitting. Make sure that they follow up. So if you work in a hospital, they're not going to follow up with you, but make sure that you tell them to follow up with their primary care doctor. To refill their prescriptions or to get them set up in the community with some other information. So again, those benefits that we see, it decreases your risk of developing diabetes. It's going to improve your heart and lung function, and it improves your life expectancy by 10 years. That's a lot. All good reasons to quit. So some occupational and recreational exposures that we can see that cause damage to our lungs. So asbestos, these would be, some people lived in houses that had asbestos. I don't think that happens too much anymore. I guess it could. It happened a lot of years ago. People didn't know they were living with it. People do it for a living, can get into their lungs. Patients that deal with fibers and dust, depending on what they do for a living, coal miners, on any kind of industrial fumes or smog. So if you live downtown around all those factories down there, pollen just from the trees and bushes and things like that. Patients can be allergic to animals. Woodworking, the sawdust that comes off can cause allergies and cause issues with our lungs. Airborne contaminated droplets, so pneumonia, the flu, COVID, and exposures to lead can lead to chronic pulmonary issues. So this is a picture of a normal lung here on the left-hand side, and this is this heavily exposed lung to asbestos, and this is mesothelioma. You can see how it deteriorates it and it turns it black. You're definitely not getting any kind of good oxygenation in there. All right. So our nursing assessment, what we're going to do when we get a patient, how are we going to assess them for oxygenation? So we want to know what their general health is. So when we first see our patient, if you're in the outpatient center, if you're in the inpatient hospital, you're going to do that snapshot assessment. So you're going to look at their color. Are they nice and pink or are they blue? Are they on room air, breathing comfortably, or are they on oxygen? Do they have work of breathing? Are they using their accessory muscles? Are they hunched over on their chair, you know, putting their elbows on their knees and leaning over? A lot of people that have COPD, they have to sit straight up or they lean over like that in a tripod to get more air in. So really looking at that patient and trying to determine what their oxygenation status is when you first see them. And then you want to talk about their family history. So some things can be hereditary. So you want to talk about mothers, fathers, grandparents, sisters, brothers. Do they have a history of any respiratory disease? Do any of them have emphysema? Do any of them have COPD, asthma? Do they smoke in the house? Things like that. You want to assess their frequency of respiratory illnesses, allergies, and smoking history. So do they smoke themselves? Do they live in the house with anyone that smokes? Did they, maybe they're older now, did they grow up living with someone who smoked? Did they smoke and they quit? Do they have a history of bronchitis? Do they get, when they get sick every winter, is that what they get? Do they get bronchitis? Do they have severe allergies that they have to take medications for? We want to find out what they do for a living. We want to know what their occupation is because that's going to tell us some of the things that we need to look for. What are things that they could be at risk for because of what job they do? Do they take any respiratory treatments now? Do they take albuterol every day? Do they have a rescue inhaler? If they have these things, it's going to be indicative of some type of respiratory issue. Have they had any pulmonary tests? Usually we don't just order pulmonary tests for any reason. So if they've had pulmonary tests in the past, it's going to be an indicator that they've had some kind of pulmonary issue. Patients sometimes forget about things until you remind them. So they might be like, oh yeah, a couple years back, I did have a really bad pneumonia and I had to have this pulmonary function test. So sometimes it jogs their memory. Let's talk about their exercise tolerance. So if you ask, do you work out every day? No, I can't work out every day. I try to, but I have the worst problems breathing. Well, that's going to signal to you that there's some kind of a problem there. Do they have pain when they breathe, when they exercise? Do they get fatigued very easy? These are all things that would prompt you to dig a little bit deeper because these could be signs of some kind of underlying issue. So there is a focused assessment guide in your book. It's on page 1493, box 39-1, that will guide you through that focused assessment for oxygenation. And then there's also some questions on page 287, box 19.1. That's going to be questions for the client with dyspnea, if you guys want to read that. So we said we're going to look at that general appearance. We're going to look, are they distressed? Are they restless or are they anxious? So some patients, they might just feel a little off. They might not even realize that their breathing is bad, but they might feel like something's just not right. That feeling of impending doom, they can get very restless. If they actually feel like they can't breathe, then they get very, very anxious, obviously, because it's not a good feeling not to be able to breathe. So really make sure you're looking at that general appearance, looking inside at their mucous membranes. What color are they? Are you seeing cyanosis? Are you seeing pallor? Do you see those accessory muscles? Then we want to check their level of consciousness. So if you don't have enough oxygen in your blood, you're not going to be able to properly perfuse all your organs. So your kidneys, your liver, your brain. Your brain is an organ. So one of the first things we'll see in people is that they change this level of consciousness. They all of a sudden start saying crazy things. Are they alert to themselves? Do they know where they are? Do they know what time it is? Are they completely confused? Is this an acute change? Has he been like this before? Is this his baseline? You want to look at that skin color. Do they have pallor? Do they have cyanosis? Do they have that bluish discoloration? Look at that respiratory effort. What's their rate? What's the depth? What's that effort look like? What's the rhythm? Is it abnormal? Is it labored versus non-labored? Accessory muscles, flaring of the nostrils. We see this a lot with babies. And then you also want to look at the shape of their chest. So patients with COPD will have what we call a barrel chest. And then you want to look at the symmetry of those chest movements. Another side effect that we see of patients that have chronic oxygenation issues is finger clubbing. So this is a condition that occurs when the tips of the fingers are enlarged. The nail beds kind of like arch a little bit because the soft tissue beneath the nail bed has increased. This is because of a lack of oxygen. I can't talk. We want to inspect the nose for any signs of injury, inflammation, any tracheal symmetry. Maybe they have some kind of injury or something happened, or there's like a deviated septum or tumor, something's blocked and they can't breathe in. We want to assess for any kind of dyspnea, so shortness of breath at rest, and then dyspnea with exertion. So maybe they're fine when they're sitting, but when you get up and walk them to the bathroom, it's really hard for them to recover. They really start to have an increased work of breathing. Do they have an increased or a more frequent cough? If they have a cough, is it productive? If it is productive, you want to ask more questions. What are you bringing up? What color is it? What consistency is it? Is it thick or thin? Is it green? Are you able to get it up or are you swallowing it back down? Whenever you have a patient that has a cough and they can bring something up and you suspect some kind of respiratory issues, get a sample. Even if the doctor doesn't want it, it's better to have it if they cough it up because then they can send it off and do a culture on it and try and determine what kind of bacteria is in there. When you listen to the patient, do you hear any wheezing, inspiratory or expiratory? And then are they coughing up any blood? That's hemoptysis. So we're also going to do palpation. We're going to talk about percussion. You know we don't do percussion, but we are going to talk about it. So palpation, this is when the nurse palpates the chest wall. You're going to look for any kind of tenderness. Do you feel any masses, any swelling, any abnormalities? You're going to palpate that PMI, which is the point of maximum intensity. You're going to palpate those extremities. You're going to look for skin color. We're going to be checking cap refill. We want to feel those pulses. We want to make sure that we're doing bilateral comparison. So we're going to check the right pulse and the left pulse. We're going to do the same thing with the lower extremities. It's possible that sometimes we have great pulses in our upper extremities because they're close to the heart. When we get all the way down to the feet, sometimes we don't have great pulses because they're further from the heart. We want to check our extremities for edema. Palpable vibration when the patient speaks. So I don't know if you guys remember this from assessments back last semester, but we would have them where we would tap on their back and have them say 99, 99, 99. And if you would hear that vibration, that would be indicative of fluid. And then sometimes we have an increase in fremitus from certain lung diseases, and then if a patient has pneumonia. So percussion, this is where that experienced nurse performs percussion on the chest wall. She places her fingers on the chest wall and taps with a finger on the middle finger of the opposite hand. They're listening for a resonant, which is a normal low pitch. They're looking for the intensity, how long it lasts. If they hear hyperresonant, that's an abnormal low pitch. Those can be indicators of emphysema and neurothorax, but we are not doing that, and I won't quiz you. That won't be on the test. All right, so normal, we have to talk about normal sounds so that we can be able to differentiate between normal and abnormal. So normal breath sounds, we have vesicular sounds, bronchial sounds, and bronchovesicular sounds. So those vesicular sounds, that's air movement in through the bronchioles and the alveoli. It's going to be quiet and it's going to be low pitched. Our bronchial sounds are air movement through the trachea, and they're going to be louder and they're going to be long with expiration, so breathing out. Then we have bronchiovesicular sounds, which is air movement that occurs between the trachea and the upper lung. Not going to be as loud as the bronchial sounds, but not as low as the vesicular. So it's going to be like a medium pitch. So those are all the normal breath sounds. We also have abnormal or adventitious breath sounds. So we have crackles and wheezing. So crackles, you'll also hear people say rails. They're used interchangeably. This is, you will hear these when air movement results from either a delayed opening of deflated airways or when it goes through fluid. So it sounds like, says that it sounds like hair, rubbing hair strands together. Maybe it sounds like popcorn or like crackles. Like if you ever have that, those little things that come in packages sometimes that wrap things that you can crack if you move them around together, that's kind of like what crackles sound like. Wheezing. So wheezing is your book says, a continuous musical sound that can be heard during inspiration and expiration. It is kind of a high-pitched sound. It's not always high-pitched. Sometimes it can be low-pitched. You can hear it in the front, in the back, during inspiration and expiration. Rhonchi sounds like crackles. So you can always determine if a patient has crackles or rhonchi if you have them cough. If you have them cough, rhonchi should not be on this slide by wheezing. So you guys should take that out. Wheezing and bronchi are not the same. I'm not sure why that's in there. That's a typo. Go ahead and cross that out. If you think that they have crackles, have the patient cough a few times. If it goes away, it was rhonchi. It's basically the fluid that kind of gets trapped there, and as they're breathing in, you hear it. But if you cough and it moves, then it's not crackles. It's considered rhonchi. So diagnostic tests that we can do. So we all know that we can do an arterial blood gas. So we're going to look at the pH. We're going to look at that PaO2, which is that partial pressure of oxygen in the arterial blood. We're going to look at the PaCO2, which is the partial pressure of carbon dioxide. And we're going to look at the HCO3, which is the bicarbonate concentration. So patients that have respiratory issues, depending on what they are, they either cannot get oxygen into the blood or they can't get CO2 out. It's either going to be one of those two issues. So the blood's pH, the O2 carrying capacity, the level of oxygen, the carbon dioxide, and the bicarbonate ions, these are all going to contribute to respiratory oxygenation issues. And by looking at those arterial blood gases, we're going to be able to determine the levels of those and try and figure out what the issue is. You know, when we do an arterial blood puncture, we can do it at the radial artery, the brachial, or the femoral. The femoral, usually it is the radial that we do. So things that can affect our ABGs. So when we overbreathe, also called hyperventilation. So these are your patients that are having anxiety attacks. They're overbreathing. It's going to cause elevated PaO2. So that's going to be respiratory alkalosis. We can have hypoventilation with certain neuromuscular diseases. We'll see this with chronic obstructive pulmonary disease, COPD. If there's insufficient oxygen in the atmosphere, it's going to cause a decreased PaO2. Elevated PaCO2 in clients with COPD. Patients that don't have adequate ventilation if they're on a mechanical ventilator, or patients that have decreased respiratory rates. And then we're going to have decreased PaCO2 in clients who are nervous or anxious or have a condition that causes hyperventilation or a very rapid respiratory rate. All right, so some diagnostic studies that we can perform. So we can do sputum studies. If that patient can cough up some sputum, make sure you have a cup in there and encourage them to cough it and spit it in the cup. Let the doctor know that you have a sample, and then you guys can send it off and do a culture and see what they're coughing up. So a sputum study is a microscopic examination of sputum and the cells it contains. We do it to determine organisms that can cause an infection. We can look and see if there's any blood or pus in the sputum, and we can also use it to determine certain cancer diagnosis to see if there's any malignancy in it. Usually you can have your patient cough it up on their own if they can. Sometimes we can do a deep nasal suctioning. We can get a sample that way, or if the patient is having a bronchoscopy, we can go in and get a sample at that time. We can monitor their their oxygen with a pulse oximetry. So this is a non-invasive method. This is the little thing, the little probe that we put on the finger. So non-invasive, it measures that arterial oxyhemoglobin saturation. So that's our SpO2 in our arterial blood. We know that a range of 95 to 100 is going to be normal. Values less than or equal to 90 are abnormal, and they indicate oxygenation to the tissues is inadequate. So when I say this, there are always exceptions to the rule. So if you see a patient that is 90 or less, you should definitely inquire more and find out what's going on. It is not normal, but you will see some doctors will say if your patient has emphysema or they have COPD, they're okay to live at a low level, not in the 80s, but 90 would probably be the cutoff. 90 to 92 is where we see these people usually live. Their drive to breathe results because of lower amounts of oxygen. So if we give them too much oxygen, it's going to cause them to become hypoxic. It does the opposite because they're used to having a very decreased, a lowered amount of drive to what causes them to breathe. So sometimes 90 is normal, but for the most part, if you see 90, under 95, you guys should say, hey, what's going on? This is a problem. And then there's some nursing guidelines on page 289, box 19.1, you guys can look at. We can also do x-rays. So radiography will look at the size, the shape, and the position of the lungs and other structures of the thorax. Usually the purpose of these is to screen for certain asymptomatic diseases. And then we diagnose tumors. We can look to see if there's any kind of foreign bodies in there. We usually do this a lot with kids because they eat things that they shouldn't, and any kind of other abnormal condition. We can do a pulmonary angiograph. So this is a radioisotope study that can view the arterial circulation of the lungs. So we would perform this to detect a pulmonary embolism and also different kinds of abnormalities. So when we do this procedure, we don't actually do this procedure, but when it's performed, a catheter is inserted into the vein in the arm, and it's threaded through the right atrium and ventricle of the heart into the pulmonary artery. Once it gets there, they put a contrast dye through the femoral artery. So it's really important before the patient has this test that we determine if the patient has any allergies, especially to iodine and shellfish and contrast dye. Then the x-rays are going to be taken to help see that distribution of all that radiopeg material, and it can identify any abnormalities. So for nursing, you're going to want to make sure they don't have any allergies. This is important. You guys need to know this. Make sure they don't have any allergies. And then when they come back, you're going to want to monitor them. So they will call you and say, Trish, I'm going to send Mrs. Jones back. She just finished her test at a certain time. The time started at 2 o'clock. They have to be on bed rest for 4 more hours. So they always tell you the time that they finished and the time the bed rest started. When they get back to you, you are responsible for making sure that the client stays on bed rest. So you're going to want to let your tech know, Mrs. Jones came back. She's on complete bed rest. Do not get her up. Do not sit her up. You are going to be inspecting those puncture sites wherever they went in. You're going to be checking that dressing. Usually they're going to have a pressure dressing on there. You're going to make sure that it's clean, that it's dry, that it's intact, that there's no blood coming around it. If there is, you're going to want to reinforce it and let the doctor know. You're going to check for any swelling, any kind of discoloration in the area. If a hematoma were to form, which is just like a big ball of blood under the skin. And then you're going to want to do pulse checks. So you're going to want to check those pulses distal from the area that had the test done. So absent or diminished distal pulses are going to be an extreme emergency. You are going to want to notify the doctor right away, absent or diminished distal pulses. And then you're going to also want to check that capillary refill because you want to make sure that nothing was compromised went in and there's no abnormal bleeding in there. So you want to make sure that they had good cap refill and good pulses. It would be a good idea if you had this patient and you knew that he was going for that procedure to make sure you did good pulse checks before they left, because maybe he was already baseline diminished and then he comes back and you're like, well, I don't know if this is really diminished or if this is his baseline. So you would want to, it's a good idea to always check your pulses before they go too, so you have a good comparison. So then we can do lung scans. So we can do that VQ scan that we talked about earlier in a couple slides back. That's that ventilation perfusion scan. We can do a gallium scan, and we can do a positron emission tomography, or it's also called a PET scan. We can also perform a bronchoscopy. So this is where, this is kind of an invasive procedure. We go in and we do a visualization of the larynx, the trachea, and the bronchi. Usually we do this when we want to go in and get a biopsy. Either it could be a biopsy of a lesion, we might want to get a sputum specimen, or sometimes they will do it to go in and do what they call aggressive pulmonary cleaning. So go in and get all that junk that's in there, suction it out, clean it out, so that the patient can have good breathing, or sometimes if there's a foreign body in there, they might have to go in and get that. So before your patient would have this bronchoscopy, you as the nurse would want to make sure that that your client is NPO at least 6 hours prior to the test. Being NPO decreases that risk of aspiration. You don't want any food in there. If they vomit because of the medication we give them and then they aspirate, they already have lung issues, so we don't want any more. We might give the patient atropine to help dry their secretions. And then sedation that is going to they usually will give the patient some type of sedation that's going to help depress that vagus nerve. So if they're doing this procedure and the vagus nerve is stimulated, it can cause kind of like a train reaction. So you can have hypotension, your heart rate can drop, so you'll have bradycardia, and then you can have the development of certain arrhythmias. So they usually give a sedation. And then post-procedure, when the patient comes back to you, again, you're going to be observing for bleeding, any kind of broncho or laryngeal spasms. So you're going to be listening to those lung sounds. You're going to be monitoring their oxygen levels, looking at their color. You're going to make sure that they're not aspirating, and then you're going to watch those white blood cell counts to see if they're getting any type of an infection. So more diagnostic tests, we can do a laryngoscopy. So this is a direct visualization of the patient's larynx using a laryngoscope. We use this test to diagnose lesions. We can look at it to think if there's some kind of abnormality with the larynx, it will determine the function, and we can look to see if there's any inflammation in that area. We can do a mediotonoscopy, which provides visualization of that mediastinum. We can go in and do lymph node biopsies. We can look at the lymph nodes to see if there's any kind of abnormalities. We can do a thoracoscopy, which is an examination of the pleural cavity. So sometimes we have to go in to remove fluid. Sometimes we go in and we send off samples because we think that they might have metastatic cancer that has spread somewhere. So we want to get a sample of that fluid and send it off for cytology. And then we can do biopsies. And then thoracentesis. So we see these done all the time in the med-surg setting. This is where we go in and we remove excess air or fluid from the visceral and the parietal flora. What they do is they insert a needle into the chest wall and they pull out any air that's in there or any kind of fluid. If the fluid is purulent, that would be an indicator of an infection, and they usually send off the fluid to check it. They do cultures to see what it is, and then of course they can also do it for cytology if they think there's any malignancy involved. Procedures performed for infections. So we would want to do a culture and sensitivity or a microscopic examination. So we can take those fluids out. And like we said, if they're purulent, that would be a sign of infection. Sometimes if there's an infection in there, they can, when they're taking fluid out, they can instill medication into that pleural space that will help fight off an infection. Usually after the procedure, the patient remains on bed rest and usually on the unaffected side for at least an hour because we want to be able to promote lung expansion. They usually do an x-ray after they do this to make sure that they haven't punctured the lung. Complications can be a pneumothorax, which is where your lung collapses. You can have a subcutaneous emphysema, which is where air accumulates in that subcutaneous tissue. You could develop an infection. You could develop pulmonary edema. And then because of the swelling or the fluid that accumulates, you could have cardiac distress. So this is a picture of a thoracoscopy. This is where they go into the pleural space there through the ribs. And this picture up here is showing how they would take off a piece of that tissue there to send off for a biopsy. So we can do thoracentesis at the bedside. I have seen it done at the bedside in emergent situations. Normally we send them down to what we call IR, which is interventional radiology, and they do it down there. But when they do it at the bedside, this is the position that they put the patient in. And usually when they're in IR, they're also in this position too. So some nursing diagnoses that we may see with our patients that have oxygenation issues. So we have ineffective airway clearance, impaired gas exchange, ineffective breathing patterns, activity intolerance related to imbalance between oxygen supply and demand, anxiety related to feeling of suffocation, because remember, these patients can't breathe and it's very scary. Fatigue related to impaired oxygen transport system. And then page 1499 in your book goes over a couple more examples of your nursing diagnoses you guys can take a look at. So some examples of outcome identification and planning. So we would want our patients to demonstrate improved gas exchange in the lungs by an absence of cyanosis and a pulse oximetry reading more than 95. So this is a great example of that measurable outcome. We will have the absence of cyanosis, and they're going to have a pulse oximetry reading of 95%. So you guys are going to be going to clinical, and you guys are going to be doing some NPAs. I'm going to put your lab paperwork, your clinical paperwork up. And you guys are going to start to do these NPAs, and you're going to really start working on your outcomes. I know you didn't have a lot of time last semester to really get in and dig in and do these, but you're going to have a lot more experience this semester. So you need to really work on developing those measurable outcomes. We want them to demonstrate self-care behaviors that provide relief from symptoms and prevent further cardiopulmonary problems. So a lot of these patients have chronic issues. So having them develop self-care behaviors is really important because they need to know how to manage these diseases when they're not in the hospital setting and they're back at home. So how can we implement some of these outcomes? Well, we can decrease their exposure to toxic gases, to smoking, to allergens, particulates. We can make sure that they're following a specific diet. So we're monitoring their fluids. They're eating smaller portions. They're eating reduced calories. Comply with prescribed exercises, and then we can help reduce anxiety. So a lot of patients that have COPD take anxiety medicines on a regular basis because they always feel like they can't breathe. So that is one common finding that you will see with patients who have COPD. All right, so promoting comfort. So what can we do to help our patients that can't breathe be comfortable? So we can position them. So positioning them will allow free movement of the diaphragm and expansion of that chest wall. If we can allow the diaphragm to freely move and really get a good expansion, we're going to be able to get more oxygen in, and we're going to be able to oxygenate all of our body organs, and the patient's going to feel better. So we can put them in a high Fowlers, we can sit them in a semi-Fowlers. These are all great positions because they help with that lung expansion, and they're beneficial because they help secrete, they help to get rid of all those secretions. So we say all the time, these patients that have pneumonia or they come in for surgery, we want them up out of bed. We want them sitting in the chair to develop so that we can prevent them from developing pneumonia and getting all those nasty secretions. You will see that some patients with COPD won't even sleep in a bed. They sleep in a chair constantly because that's where they're comfortable. We want to maintain adequate fluid intake. So if your patient has a lot of secretions, we can help keep their secretions thin by encouraging them to drink. Now, you have to take into the consideration if they have fluid restrictions. But if they don't, and they don't have any chronic heart failure, then having them drink 1.9 to 2.9 liters a day. So that's 2 to 3 quarts. So the more fluid they drink, it's going to thin out those secretions. The thinner they are, the easier they're going to cough them up. We can give humidified air, which will help with their breathing. It helps moisten the nasal passages, and it helps prevent drying out and bleeding. We can encourage deep breathing. So we use this to help slow the patient down, prevent them from overbreathing, prevent them, used to help overcome hypoventilation. They're taking deep breaths in through their nose and out through their mouths. So you instruct that patient to make each breath deep enough to be able to move the bottom ribs. That's what they should feel when they're taking a deep breath in. And then you know how I feel about the incentive spirometer. You guys should make sure every single patient that you come in contact with has an incentive spirometer. If they're in the hospital, they're not moving around, they need an incentive spirometer. This maximizes their lung inflation, and it prevents or reduces atelectasis, which can lead to infections and pneumonia. And then we can teach our patient pursed-lipped breathing. So we teach this to help reduce the symptoms of dyspnea and panic. So this is where the patient exhales through pursed lips. It creates a smaller opening for air movement, but then it effectively slows down and prolongs the expiration. So what they look like is they should be going like that. That's an example of pursed-lipped breathing. So we always can help these symptoms medically, so we can give inhalers. So inhalers can be administered to help open those narrowed airways. So those are your bronchodilators. We can give mucolytic agents. So these are your mucinexes. These are going to liquefy or loosen those thick secretions, so when the patient does cough, they can cough them up and get them out of their chest. We can give steroids to reduce the inflammation in the airways. These medications are typically administered via a nebulizer. So we're talking about like some of your inhalers, some of those bronchodilators, we can put them in a nebulizer. We can put them in metered dose inhalers, so MDIs, or we can use a dry powder inhaler. So you have a DPI, an MDI, and then your nebulizer. So your metered dose inhalers, these are your MDIs. These are pressurized devices that contain an aerosol powder of medications. When the client holds it up to their mouth, they push on the pressurized part of the canister, and a predetermined amount of medication is delivered and the patient breathes it in. You can see page 335, chart 21, box 21.2 is going to exactly show you how you would teach patients and family members to use those MDIs. Our DPIs, which are a little different than our MDIs, these are breath activated. So you turn the appropriate dial to how much medicine you're going to take in. The patient takes a very quick deep breath, and this activates the flow of medication. So the medication isn't pushed. It doesn't come out until the patient breathes in. And then we have spacers. So spacers you can add on to the end of an inhaler. And what it does is it extends the amount of time that the patient has to inhale the medication. So especially with our older patients or patients that have cognitive dysfunction, even us sometimes, just that we don't have any issues. It can be very hard to calculate the medication, push down the button, and inhale at the same time. So a spacer just extends the amount of time after you hit that button, leaves that medicine in there traveling through the tube so that you have time to inhale it and get the medication. You guys know what the incentive spirometer is. We've been talking about that. Sometimes you will see the doctor orders chest physiotherapy. So this is performed by physical therapy or respiratory therapy. This is not anything that the nurse does. This helps to improve breathing. It helps loosen and remove mucus from all of the breathing passages. So sometimes they'll put patients in a vest that's hooked up to a machine and it'll shake, 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 shake for a predetermined amount of time. Other times they will put the patient in a certain position and physical therapy will come in and they'll, kind of like tap on their back in certain areas to get all that stuff loose. It's performed differently by different people, but that's pretty much the gist of chest physiotherapy. So this example here, this gentleman actually has an inhaler with a spacer. So that blue part that's going into his mouth, that is the spacer. So when we are educating our patient how to use a metered dose inhaler, these are all the steps. So we would teach the patient to attach the stem of the canister into the hole of the mouthpiece so that the inhaler looks like an L. And you can see from the picture, that's exactly what it looks like. If a spacer is used, you want to attach that spacer to the mouthpiece on one end and then the MDI on the other end. You want to make sure you shake the canister really good because you want that drug to be distributed into the chamber. You slowly exhale through pursed lips. The patient then seals their lips around the mouthpiece or hold the inhaler a few inches away from the mouth if they don't have the spacer. Compress the canister between the thumb and the fingers and slowly inhale. If you're not using a spacer, you must compress the canister and inhale at the same time. So that's why sometimes for some people that spacer is just easier. You will release the pressure on the canister, but continue inhaling as much medication as possible. Let's see. Inhalation should be for 5 seconds in order to be able to breathe in all the medication completely. Patient then withdraws the mouthpiece. They hold their breath for 10 seconds. They count to 10 slowly. Obviously, not every patient is going to be able to get to 10, especially if they're having oxygenation issues. They might only get to 3 or 4. You want them to just try and do it as long as they can because the longer they hold it, it's going to allow that medication to reach the airway of their lungs and it's going to be more effective. Those patients are then going to exhale slowly through pursed lips again. And then if a second dose is required, you're going to wait a few seconds, a couple minutes, and then repeat the procedure again. Usually respiratory therapy does this in most clinical settings, but nurses can do it as well. So that incentive spirometer, it is going to assist the patients to breathe in slowly and deeply, and it's going to help sustain maximal inspiration, so breathing in. The device ensures that a volume of air is inhaled and the patient takes deep breaths and works the respiratory muscles. We use this to prevent or treat atelectasis. So for nursing care, we're going to make sure that the patient's in the proper position. We want them sitting up in bed. We don't want them all slouched over. We definitely don't want them laying down. We want them to be in an upright position with their chest expanded so that they get the maximum benefit from the incentive spirometer and get the most amount of air in. We're going to teach them how to use it, and we're going to encourage the use. So when I teach a patient how to use it, I make them use it in front of me and do it 3 or 4 times so I can see that they know how to do it. And then I tell them how much I want them to use it. So usually the gold standard is 10 times an hour. I tell them, they look at you like you're crazy when you say 10 times an hour. 10 times an hour is not terrible. I tell them that every time a commercial comes on, do it. They can do 10 during a commercial, and then you have it done for the hour. And I make sure that I check back on them throughout the day. Are you doing your incentive spirometer? How much have you done? There's usually a spot in your documentation for the incentive spirometer, and it wants to know, did they do it? What volume did they reach? Were they compliant? How many times an hour are they doing it? Are they tolerating it? So you want to document that use. And then you want to set realistic goals for the patients and record the results. And then there you go, use it 10 times per hour. There's more information in your book on page 334. You guys can read. So this is the incentive spirometer. And the nurse is going to teach the patient to sit upright unless contradicted. You're going to mark the goal for inhalation. What goal do you want them to reach? So it's hard to see on that incentive spirometer, but usually they have one side of the incentive spirometer will have numbers. So some people say, try and reach 1,500. Then on the other side of the spirometer, there's 2 arrows about this far apart. In between the 2 arrows is this little blue ball. As they start breathing, that little ball goes up. I never tell patients to get a certain number, because what happens is they'll take a big deep breath in, and once it hits that number, they let it go. They're not getting the maximum effect from it. So what I tell them is to not look at that side, to look at that little ball. As they start to breathe in and that little ball starts to rise, their goal is to get that little ball in the middle of those 2 arrows. And once they get it in the middle, they should continue breathing in as long as they can to sustain that ball in the middle. So that keeps them, it gives them a goal. And then when they reach it, they continue to keep breathing in, because if they just take a, and then they're done, that's really, is it going to help? Yes, but it's not going to be as effective as if you teach them the other way. Then you teach them to exhale normally. You place the mouthpiece in the mouth, make sure that they seal their lips around it. They inhale slowly, hold their breath for 2 to 6 seconds, exhale normally, and then they repeat that exercise 10 to 20 times an hour while awake or as ordered. And do not rush them during the procedure, and slow down if dizziness is experienced. So sometimes when they do that the first couple times, they'll cough. It'll make a cough. That's good. That means it's working. You're bringing air in. So you tell them that coughing is good. And then sometimes, because you're bringing that air in and you're using so much, force to breathe in, it can cause them to be dizzy. So just tell them to slow down and maybe only do it 5 times an hour until they build up a tolerance. But they will notice if they start to do that and you really stay on them, they will increase by the end of your shift how much they can breathe in. It's very, very effective. Then we have the mini nebulizer therapy. So this is a handheld apparatus. It's just like a regular nebulizer, but it's mini. That disperses a moisturizing agent or a medication, usually a bronchodilator, into the lungs. In order for it to be effective, the device has to be making that visual mist that you've seen, if you've ever seen a nebulizer or if you've ever had one. So the nebulizer, the medication goes in, they pour it into it, and it's going to mix with the oxygen, and it's going to disperse these fine particles of liquid medication that the patient is going to breathe in, and it's going to get deep into the passages of that respiratory tract. And then they're going to be able to absorb it, and it's going to open everything up. The patient keeps the mask on and that high level of oxygen until all of the nebulizer has been inhaled. And you'll see, because that mist will kind of diminish. Most patients that get this, that do nebulizers at home, they usually know when it's done, they can tell. So nursing care, you're going to want to instruct the patient how to use it. You're going to tell the patient that when they're getting it, they're going to breathe slow. They're going to take deep breaths through their mouth, and they're going to hold a few seconds at the end of inspiration. So they're getting all that medication in. You may also encourage coughing exercises, because that's going to help mobilize those secretions after treatment, and hopefully they'll be able to cough them up. And then you always want to assess your patient before treatment and evaluate the response after treatment. So if I hear a patient that sounds very tight. There's not a lot of air movement through there, or they have a lot of wheezing. I will call respiratory therapy and say, can you come give them a treatment? Well, after the treatment is done, I go back in again and I listen, because you want to hear a change. You want to know that that medication has been effective. So definitely follow up with those good lung assessments after they use their inhalers or if they get that nebulizer treatment. So these at the bottom are your metered dose inhalers. This is your DPI on the right. That's the dry powder inhaler. And then this is a spicer. Oh my God, I've taught this morning for the other class. I'm so tired, I don't even know what I'm saying. A spacer. So they also call it a holding chamber. Some people call it that. Most people call it a spacer. Whoops. So common mistakes that get made when patients use their MDI. So sometimes they don't shake the canister. When they don't shake the canister, all the medicine doesn't get into the chamber. It doesn't all get mixed up. And when they inhale, they don't get a good dose of the medication. Sometimes they hold the inhaler upside down. So you want to make sure that when they're doing it, if it's a patient that's really sick and you're giving them the inhaler, you can hold the inhaler for them and just tell them when you put it up to their lips to take a deep breath. You can do that for them. Inhale through the nose rather than the mouth. They take a deep breath in. If they're breathing through their nose, they're not getting that medicine in. You just have to really tell them to breathe through their mouth so they get all that medication. Sometimes they breathe too rapidly or too soon before the medication comes in. Sometimes when they take these medications, they'll feel like a cold feeling on the back of their throat. And if it's the first time they've ever had it, it kind of startles them. So they stop breathing it in because they feel like it's going to constrict their airway or something. It's just an uncomfortable feeling. So educating your patient about that, if they're getting a medication that causes that, let them know that it's going to happen and that nothing bad is going to happen and that they should keep inhaling. Some patients fail to hold their breath after inhalation, either because they weren't instructed to, so we didn't give them good instruction, or maybe just because they can't. They might not be able to hold their breath, depending on what kind of oxygenation issue they have. And then sometimes they will inhale 2 sprays with 1 breath. Again, for some people that aren't very coordinated, it's hard to spray and breathe at the same time. So those are some of the common mistakes that we see. Chest physiotherapy, we're going to talk a little bit more about that. So we use this to help loosen and mobilize secretions. It helps us increase the mucus clearance. It is generally performed by respiratory therapist and physical therapist. It includes postural drainage, chest percussion and vibration, and breathing retraining. So effective coughing is going to be a very important component. It's going to help get all of the yucky secretions out. Goals of chest physiotherapy, we want to remove those secretions from those bronchial areas. We want to see an improved ventilation, so their oxygenation is going to improve. And then they're going to be able to effectively use those respiratory muscles, which will also improve their breathing. So you can go to page 333. There's a nice figure 21.3 on there that shows you the different positions that they use for postural draining. So if patients have some type of an infection, which is causing their breathing problem, pneumonia, COVID, we can give anti-infectives, antibiotics. We can give bronchodilators. They're going to help dilate the airways, and they're going to help decrease that edema and the spasms in their airways. And then if we dilate everything, it's going to improve that good gas exchange. It's going to help with inspiratory and expiratory wheezing. And it's going to decrease the force expiratory volume. We're going to talk about what all those terminologies are in a couple slides. We're going to give antihistamines. So these help to combat the effects of histamine and reduce symptoms of inflammation. So we know when histamines are released in our body, it causes inflammation. So antihistamines is going to bring down the inflammation. If it's an asthma attack, something like that. We're going to give anti-inflammatories to decrease inflammation in the airway. Corticosteroids, it's going to assist with bronchodilation, and it's going to help remove the secretions. It's going to decrease inflammation. We can give antitussives and cough suppressants. Sometimes patients, if they have a non-productive cough and they don't have anything in their chest, we can give them medicine to suppress their cough. It's not always a good thing to suppress their cough. If they have a lot of secretions and they have pneumonia or something like that, we want them to cough. We want them to be able to get all that stuff up. So we don't want to suppress the cough. So this is going to be kind of like on an as needed basis. We can give expectorants. So these are your like Mucinex as an expectorant. It's going to thin and loosen up that phlegm, break up the congestion, and the patient's going to be able to cough it up and get rid of it. And then, of course, we can give oxygen because we want to improve oxygenation so that all of their body or all of our organs stay properly oxygenated and functioning until we can resolve this respiratory issue. So corticosteroids, these can be, these are going to be our preventative medications. So some patients get them for the long-term treatment and prevention of bronchospasms. It reduces inflammation in bronchi. So your COPD patients will stay on corticosteroids. Patients that have asthma, these patients take corticosteroids on a long-term basis. We have something called leukotriene modifiers. This is prophylaxis and treatment of chronic asthma. It helps reduce inflammation. We can give certain vitamins. We want these patients to get vaccines. Important, you guys need to know that. We want them to get the flu shot. We know that respiratory illnesses can cause mild to severe illness and even death. They can develop into pneumonia. Your high-risk people are your chronic health conditions, so COPD, asthma, heart and lung disease, and any patient over 65 years old. We also want them to get the pneumococcal vaccine because we don't want them to get pneumonia. It's an infection that's caused by a bacteria called pneumococcus. It can be fatal, can result in long-term issues, hearing loss, brain damage, even death, especially in those patients over 65 and patients with chronic health conditions. And then we want to be able to provide supplemental oxygen therapy to help get them over the hump, keep everything oxygenated, all of our organs perfused properly until we can resolve their respiratory issue. So oxygen is a tasteless, odorless, colorless gas. What we have room air, what we're breathing now is what we consider 21% oxygen. That's what we breathe every day with no supplementation. Oxygen therapy will help increase the amount of oxygen that's transported in our blood. Our blood goes to our kidneys, it goes to our liver, it goes to our brain, so it's going to help get more oxygen to those areas. Oxygen does need to be prescribed by a physician. You would want to check your hospital policy, but most policies have a nurse-driven protocol. If you go in and you have a patient who is desatting and they're 80 on room air, you're not going to wait for an order to put them on oxygen. You are going to get tubing and you are going to put them on oxygen at a high enough rate to get them to a safe level. So it might not be nasal cannula. You might have to move to a non-rebreather. You might have to move to a different type of a mask. It just depends, but you do whatever you can do to get that oxygenation up, and then you call the doctor and then they'll come and put the order in. Oxygenation, administration of oxygen at a greater than 21% rate will improve hypoxia, hypoxemia. It's going to help decrease the patient's work of breathing, and ultimately it's going to reduce the stress that we see on our myocardium, which is our heart. We're going to assess our patients for signs and symptoms of hypoxia. What are some signs and symptoms of hypoxia that you might see in your patients?
Clapping fingers.
Mm-hmm. Good job, Shanoa. What else?
Cyanosis.
Yes. Where might we see that?
Around the mouth, around the nose, could be in the hands, the feet.
Yep. Very good, Amy. What else? Cyanosis, clubbing fingers. What else? How might they present? How might they look sitting in the bed?
Dyspnea, trouble breathing. You can actually see them trying to nasal flaring.
Yes, good job, Dina. They're going to be using those accessory muscles. They may be hunched over. They might be holding their chest. They're going to be breathing rapidly. Very good, guys. We're going to put a pulse ox on them because we want to know what their oxygen is. And then if it's needed, they might need an arterial blood gas because that's going to be a more accurate indicator of their oxygenation status. So we need to be careful when patients are on oxygen, okay? We need to be able to prevent fires and injuries. So I don't think it's on here, but you want to tell your patient not to smoke in their room. So they're not allowed to smoke in the hospital, but I've had a handful of patients that smoke in their room and they can blow the whole hospital up. So if they're smoking, you might have to call security. You really need to tell them they cannot be smoking in their room because it's combustible. You want to make sure that the electrical equipment in the room is working. So look at those electric bells, the cords, the call bells. You want to make sure that they don't have any electric razors, radios, suction equipment, that all that stuff is in good working order and it doesn't emit any type of a spark, because if it does, it can ignite. You want the patient to avoid wearing and using synthetic fabrics because they tend to build up static electricity. You want to avoid using oils in their area. Oil can ignite spontaneously in the presence of oxygen. And you want to avoid Vaseline on the patient's lips or their nose. So some patients will say, my nose is so dry, it's breaking out, it's really raw, I need some Vaseline. No, it can cause a fire. We can add humidification to their oxygen, and that helps moisten their nasal passages so that they don't get a bloody nose. And then we can use like chapstick or something like that for their lips, but no Vaseline. So these are our oxygen devices. You guys need to know this chart, okay? You're gonna see it on your exam. So when we talk about giving a patient nasal cannula, so nasal cannula is, I'm pretty sure we're going to have a picture of it down here somewhere. I thought we did. It's in your book. Nasal cannula is just the long tubing with the two little prongs that go through the nose and then it wraps around the ear and goes under the neck. That's your nasal cannula. When you put a patient on nasal cannula, you can give them between 1 liter a minute or 6 liters of oxygen, okay? If they're getting 1 to 6 liters on that nasal cannula, they're going to be getting about 24% to 44% oxygen delivered, their FiO2, okay? So that's your nasal cannula. If you put them on a simple face mask, you can give them higher amounts of oxygen. So a simple face mask, they can get 5 liters to 8 liters a minute. And then having that simple face mask, that's going to deliver a higher percentage of oxygen, so 40% to 60%. If we put a patient on a Venturi mask, there's a little button on there that is going to allow you to deliver a very precise amount of oxygen. So these Venturi masks, you can deliver from 4 liters a minute to 12 liters. And then the percentage of oxygen that the patient's going to receive is between 24% to 60%. If you have to put a patient on a non-rebreather, usually things are not progressing well if they're on a non-rebreather. In my facility, patients cannot stay on the med-surg floor and have a non-rebreather on. They have to be evaluated by an intensivist to be upgraded if they're requiring that kind of oxygenation, except for COVID patients. COVID patients can stay on those non-rebreathers. So non-rebreathers are going to deliver 8 liters to 12 liters of oxygen. The percentage that's going to be delivered is between 50 to 100. That's a lot. You see how much that bumped up. And then if you have a patient that has a trach and they have a trach collar and we're putting oxygenation there, we can deliver between 8 liters and 10 liters a minute. And that's going to deliver 30% to 100%. So remember, our room air, what we're breathing right now, is just 21% oxygen. And then this chart is showing you how these other devices will deliver a higher percentage and how many liters they have. So you need to know the devices, the liters that are used, and what the percentage of oxygen is that they deliver. So Nasal cannula, there's the picture. So this to the left is our nasal cannula, to the right is the non-rebreather. So nasal cannula is the most commonly used oxygen delivery device. It is a disposable plastic device with two protruding prongs that are inserted into each nostril. When you're putting it on, the prongs kind of go like this and they point down. That is how you want to put it in their nose. You want it to go down towards the back of their nose. I see some people that point it going up, not on purpose. You just don't know if you've never put oxygen in before. So just make sure those little prongs are down if you put oxygen on your patient, because it can be uncomfortable and it doesn't stay in the nose very well. The cannula is then connected to an oxygen source with a flow meter. In the hospital, it's going to be connected to the wall. If they're in a nursing home or if you're taking them for a procedure, you can get an oxygen tank and connect it to that as well. The disadvantages are that they're dislodged easily, and the low flow rates can cause dryness of the nasal mucosa. So you would need to put them on some humidification. That is something that you can do without a doctor's order. It will help moisten the nasal passages and prevent any kind of bloody noses. Some people are pretty susceptible to getting a bloody nose. And then our older patients who are confused, they pull their nasal cannula out all the time. If they're on a continuous pulse ox, you'll walk past the machine at the front and it'll say that they have like 79% oxygen. You go in and sweet little Mrs. Jones is so confused and she keeps pulling out her oxygen. So sometimes if they have respiratory issues and they're confused, you have to put them in restraints because they keep interfering with their care and they need the oxygen. And then some patients need a non-rebreather. This is usually when your nasal cannula has not been effective to get your oxygen levels back up to at least 90%. This bag is going to cover the entire nose and mouth of the patient. It delivers the highest concentration of oxygen via a mask to a spontaneously breathing patient. What happens is the reservoir bag, that bag is going to blow up when they start breathing. It's going to fill up with oxygen that enters the mask when the patient breathes in. The air that they breathe out when they exhale is going to escape through these little vents on the side. The advantage to this is it delivers the highest O2 concentration possible. The disadvantage is it is poorly tolerated because some patients have anxiety, they're claustrophobic. Obviously, they can't eat or drink or talk because they usually, if they need that, they need it on. It's not something they can take on and off intermittently. So those are the disadvantages. Then we have the Venturi mask. So this, if you see, it's a lot different than the non-rebreather. It has that long tube. And then at the very bottom there is where you turn the dial and you can give a specific amount of a rate of oxygen. So it covers the nose and the mouth. This mask allows the most precise concentration of oxygen. It has a large tube with an oxygen inlet, which is coming off the mask there. As the tube narrows, the pressure drops, and it causes more air to be pulled in through those side ports. You want to make sure when you put this mask on that the ports are always open. Usually when you open the bag, they are open, but sometimes they're not, and it's not going to work if the ports are not open. So you always want to check that. It is best suited for patients who have chronic lung disease. And then you just have to ensure that the client wears a nasal cannula during meals because they're still going to need the oxygenation, but we want them to be able to eat too. So what mask do we use for CPR? So the mask that we use for CPR is, it's a bag that we hold over top. It's the Ambu bag. That's what we would do manual ventilations if we were doing CPR. We wouldn't use any type of oxygen like this. We would be doing it ourselves. One person would be doing compressions. The other person is going to be in charge of doing ventilations. That's a good question. All right, so then we have a trach collar. So you can see the patient in the right. He has a trach, that long blue tube with that little clear piece on the end. That's the trach collar. That has a little tab that goes, a little string that goes, it's elastic, goes around the neck, and then you can loosen it if you have to do suctioning, and then when you're done, you can tighten it up again, and it goes up against there. So the tracheostomy is a surgical procedure that we make into the opening of the trachea. Some patients get tracheas and it's permanent. They will always have it. Some patients, if they are in intensive care for a certain amount of time, you can only leave someone on mechanical ventilation for a certain amount of time. If you know they're going to need mechanical ventilation for a longer period of time, you have to give them a trach. Sometimes it's just temporary. Sometimes it's reversible. Sometimes it's not. It's permanent. So you can have a tracheostomy or a laryngectomy tube inserted, and then that mask covers that area of the trach, and it provides oxygen. Some people with trachs don't need that oxygen. They're completely fine on room air. Some people require that oxygen. It's really a case-by-case basis. Then we have non-invasive positive pressure ventilation, or positive airway pressure, PAP. So PAP therapy uses mild air pressure to help keep our airways open. It helps the body to maintain better carbon dioxide and oxygenation levels in our blood, and the use of a mask or other device to maintain a seal and permit proper ventilation. So we have CPAP and BiPAP. So CPAP is continuous positive airway pressure. This helps provide what we call mild air pressure. When patients are sleeping, we use it a lot to help keep their airways open if they have sleep apnea. And then sometimes if they're having trouble breathing, we'll put them on during the day. They'll have their CPAP on. BiPAP is a higher level of requirement. In our hospital, we cannot initiate BiPAP on anyone for the first time. It has to come from the ICU. If it was initiated in the ICU and they downgrade to a med-surg floor and their breathing became compromised again, we could give them that BiPAP again because it's already been initiated once. So BiPAP is bi-level positive airway pressure. It changes the airway pressure while the patient breathes in and out. Patients should use this device every time they sleep, at night, and during naps. And then sometimes we will have to put these patients on this during the day to get them over the hump of whatever their respiratory issue is. So what are the complications of oxygen therapy? There's complications to everything. So we can cause oxygen toxicity. So this is actual lung damage that can occur from breathing in too much extra supplemental oxygenation. It can cause death, it can cause trouble breathing, coughing. So one thing you want to think about when you put a patient on oxygen is that you want to think, when can I wean them off of this oxygen? Even if his oxygen was just 79 and I had to put him on 6 liters and now he's 95, my next thought is, when am I going to wean him off? What time of the day is it? If it's 8 o'clock in the morning, by 2 o'clock, I'm going to start weaning him off again. That's always the goal, because we don't want our patients to have to go home with O2. Sometimes they do, and if they have to, that's fine. But it is our job to always reevaluate. We do have to have an order to wean, but you can call the doctor and you can say, hey, can you put in an order to wean the oxygen? So you always want to monitor that. In those patients that I was talking about that have COPD and emphysema, they have a loss of hypoxic drive. So they have chronic low oxygen. So what drives them to breathe is low numbers of oxygen compared to what we need. So if we give them, they're used to being able to breathe on 90%. So if we give them oxygen that's 95%, we can cause significant damage, and then they won't be able to breathe because they're not used to tolerating that much oxygen because they don't ever have it. It can be flammable, obviously, if you smoke or use any of those things we talked about a couple slides back. We can cause damage to the lung tissue, so the alveoli can actually fill with liquid, which can contribute and make your respiratory problems even worse. And then sometimes the alveoli can even collapse. So oxygen toxicity. So this is oxygen concentrations greater than 50% for an extended period of time, usually longer than 48 hours. what happens is it causes an overproduction of free radicals, and then it ultimately damages our cells. So what signs and symptoms would we see? So patients might complain of substernal discomfort. They might get short of breath. They might have a dry cough. They might complain of a headache, nausea, vomiting. They may be extremely fatigued. They might complain of a sore throat, and they may be very restless or anxious. So we need to prevent oxygen toxicity. So oxygen toxicity, we want to assess the need to decrease the oxygen, wean the oxygen. We want to use the lowest effective concentration of oxygen to maintain an adequate SaO2. So if I come in and I see my patient and they're satting at like 88%, I will give them 1 liter. I will keep the oxygen probe on them and I'll monitor them. If it only comes up to 90 after like 3 minutes and they're stable, I'll take it up another half of a liter. So you gradually increase the oxygen until you get the level that you want. Now, with that being said, if your patient is having extreme work of breathing and they have cyanosis, then you might want to ump it a little bit more to get that oxygen in there quicker, and then consider backing off on it once the patient is stable. And then we are going to assess oxygenation levels frequently. So the doctor may order that you do vital signs every 4 hours. Well, that's just a guide. That's when they're mandatory. As the nurse, you are always evaluating when you should do vital signs. Sometimes I will go in 1 or 2 times an hour or more to check oxygen. Sometimes I'll leave them hooked up to the oxygen, or I'll ask them to put them on a continuous pulse ox. So it'll beep if their oxygen drops down. So we don't always have to just follow those 4-hour guidelines. We need to make sure we're checking those levels when it's appropriate. So some patient teaching we need to do if our patients do have to go home with oxygen therapy. So we have those safety considerations. So we want to tell them, don't smoke with your oxygen, avoid oils and grease, alcohol and other flammables. Do not use electric razors, electric toothbrushes, hair dryers, or space heaters. We want to talk about the flow rate and the flow adjustment. We don't want them to adjust their oxygen. The doctor will have a predetermined amount that they want them to have, and we want them to follow that prescribed rate. If they're having any kind of symptoms, if they feel like their oxygen isn't enough, they should call in and talk to the doctor. We want to teach them how to maintain the equipment. So if they have an oxygen tank, it should always be secured in a holder. If they fall around or they get thrown, they can explode. So we always want them to have that little holder. We want it also to be protected from sunlight. We want to be able to teach them about any malfunction. If it's not working, what number they would call to get it fixed. Maybe we might have to tell us to call us back if they find out that their nasal passages are drier, they start to have a bloody nose, because then we can add some humidification to it. And then we want the patient to have an adequate amount of their supplies and their oxygen. So we want them to know, what parameters we want them to follow with regards to ordering it. So when your oxygen gets down to this number, this is when you should call and order it. You always want to make sure you have enough supplies with you before you leave the house. Anticipate how long you're going to be gone so that you don't run out of oxygen while you're out. And then again, signs and symptoms to report to the doctor if their breathing gets worse, if they feel like the oxygen isn't sufficient. And then just teach them, sometimes if they're going to travel, we can give them a travel bag that they can carry instead of that big canister, because it can be not very easy to travel with that. And there's a lot more tips on page 1509 if you guys want to read it. So evaluation of the effectiveness of care. So we as the nurses need to identify effective interventions and reasons why we didn't reach those expected outcomes. We need to make sure that we are implementing any nursing interventions that we planned. We want to help make sure that our patients can participate in self-care. If they can't, we want to be able to identify any deficits and make sure that we can help them. So if they don't have good oxygenation, they might not be able to walk in and get a shower. They might not be able to stand at the bedside for long and clean up. So maybe we have to help set them up on the side of the bed. Maybe we have to help clean them up. We want to have safety measures. So if the patient doesn't have proper oxygenation, they could be dizzy. They should probably be a high fall risk. If they have oxygen on them and they're walking with an oxygen tank, maybe they're not a high fall risk, but maybe they are competent enough and safe enough to get in and go to the bathroom. So we want to make sure that we have oxygen tubing that's long enough so that they don't have to take their oxygen off to go to the bathroom, because we don't ever want that to happen. We want them to be able to keep it on and use the bathroom. We want to make sure that we're implementing any pharmacological or surgical interventions. We want to encourage our clients to be compliant with their treatment. So taking their medications, following up with their providers, wearing their oxygen. And then we want to make sure that if the patients need to follow up with their primary care doctor or their pulmonologist, that we include that in their discharge instructions, and also let their families know too when we go over discharge instructions. So what are our priorities? Oxygenation saturation level, that is your priority. You want to make sure that your oxygen levels are appropriate. Airway, breathing, circulation, right? This is your breathing in your airway. We don't want our lungs to have any advantageous lung sounds, or we want them to be improving. ABGs, we want them to be within normal limits. We want to see them resolved. And then, of course, we want to have the absence of any complications. All right, so now we're going to start talking about some of our exemplars. Do you guys want to take like a 5-minute break?
Yes, please.
Okie dokie. All right, so let me pause this. All right, so we're going to talk about some of our exemplars. So the first one that we're going to talk about is pneumonia. So pneumonia is an inflammation of the lung structures, mainly the alveoli and the bronchioles, that produce excess fluid. It can be caused by infectious organisms, or it can be because they aspirate, either an irritant or fluid or even a foreign object. So it can be their food. The inflammatory process in the lung results in edema and exudate that's going to fill those alveoli and weigh them down so they can't open up, and then we can't get that good oxygenation in. Pneumonia combined with influenza ranks as the 8th leading cause of death in the United States. Those are big numbers. So we have 4 different types of pneumonia. We have community-acquired pneumonia, healthcare associated pneumonia, hospital-acquired pneumonia, and ventilator-assisted pneumonia. We're going to talk about these. So community-acquired pneumonia are usually caused by bacteria, atypical bacteria, viruses, and fungi. So bacteria, the most common causative bacterial organism is Streptococcus pneumoniae. It spreads from the upper respiratory tract to the bronchi and lobes of the lower respiratory tract. With atypical bacteria, they also cause pneumonia. It's referred to as atypical pneumonias. An example of an atypical pneumonia would be mycoplasma pneumonia, or you may have heard it called walking pneumonia. It's less severe. It is still spread from person to person via infected respiratory drops, but you don't see those big side effects like you see with the regular pneumonia. So these people still go to work. They just might be fatigued. They might have this lingering cough, maybe a low-grade fever. Viruses can cause pneumonia more commonly in infants and children, but it does happen in adults. So viruses that cause colds are going to be the influenza. And then what happens is we get the flu, and then we're so sick, we're not moving around, we're not getting out of bed. We have all this congestion, we're laying around, and then because we're not moving, all that bacteria and fluid sits in our lungs, it starts to breed, and before you know it, we have pneumonia. And then certain fungi can also cause pneumonia. Mainly we see these in immunocompromised patients or patients that have chronic health conditions. So this is a picture, a chest x-ray of a patient that has pneumonia. So if you see right here on the patient's right lung, so if you're looking at it, it's going to be on the left-hand side here. You see this white area right here? That is the pneumonia. That's what pneumonia would look on an x-ray. This actually isn't terrible. I've seen where these lungs, one side of the lung is completely black. You can't, or it's completely white. You can't see any black area at all. Sometimes it's half the lung. It just depends on how bad it is. So bacteria pneumonia, it's caused by Streptococcus pneumoniae. That's the most common. There's also Pneumoniae cerevisiae, Staphylococcus aureus, Klebsiella, and Mycobacteria tuberculosis. They can all cause bacterial pneumonia. So mycoplasma pneumonia, which is walking pneumonia, it's the most common cause of atypical pneumonia. Those symptoms are going to be less severe, but it is going to spread from person to person through respiratory drops. We have Legionella, which is also called Legionnaire's disease. So this bacteria is going to reside in basically like an aquatic environment, so waters. It's going to spread over inhalation of mist or vapor water droplets. We see outbreaks that are traced to air conditioners, humidifiers, hot water tanks, and some of your decorative fountains. And symptoms of this include fever, cough, and chest pain. And then we have PCP, which is a fungal pneumonia. You're going to see these in your immunocompromised patients. And most usual causes are from opportunistic fungi. Your non-bacterial pneumonia, these are going to be viral. So these are more common in infants and children. In adults, viruses that cause colds and influenza can lead to pneumonia. Then we have aspiration pneumonia. So this can be anaerobic bacteria. It's going to be an abrupt onset of dyspnea. The patient can have a low-grade fever and a cough. And then we have the fungi, which these spores become aerolized. They're present because of their habitat, so they can be in soil or bird droppings. That area, wherever these droppings are, can be disturbed, and then you breathe them in. And then once the lower tract is infected, it's very difficult to manage the infection, and then it's going to spread throughout the entire body. And those immunocompromised people, those are the ones that are at most risk for developing that. So what effect does pneumonia have on our oxygenation? Well, they may have little or no ventilation at all, depending on how bad it is. They are going to suffer from hypoxemia. When they have a VQ scan, there's going to be a mismatch. So this is going to occur either when the ventilation, which is our airflow, or the perfusion, which is our blood flow in the lungs, is impaired. So this is whatever the issue, whether it's airflow or blood flow, it's going to prevent the lungs from delivering that oxygen-rich blood throughout the body. And then it's going to cause a decreased surfactant. So remember that surfactant helps prevent the alveoli from collapsing, and it helps preserve our bronchiolar patency. So if we don't have enough of that, then we're going to see issues. So what are some risk factors for developing pneumonia? Well, we've been talking about this since FUNS: prolonged immobility, not getting our patients out of bed, not getting them to the chair, not having them walk around. Patients that have decreased level of consciousness, the more sick they are, the more confused they are, they're not going to be able to participate with walking around, getting up, doing things like that. So we as nurses have to do that for them. So even if you have a patient that is, so many times I get report and I'm like, did the patient get up to the chair today? No, he's bedridden. Anybody can put a chair lift or a bed lift, a underneath of a patient and use the lift if you have it in your hospital and put them in the chair. Nobody is completely bedridden. Use the lift, put them in the chair, even if it's for 2 hours a day. Make sure when they're in the bed that they're sitting upright. There are things you can do, even if they have a decreased level of consciousness. We know that the increase in age and the changes that we see along with chronic diseases like COPD, asthma, bronchiectasis, cystic fibrosis, that's usually seen in younger patients, and diabetes, these can all have an issue and cause complications that could develop into pneumonia. Then we have immunosuppression, so patients that have HIV, patients who are organ or bone marrow transplants, they take that anti-rejection medicine, so they always have a compromised immune system. Cancer patients that have chemotherapy, our asthma patients, our COPD patients that are on those long-term steroids, they're at risk for infections. And then patients that have autoimmune disorders, poor nutrition. If patients have a tracheal intubation, we can damage the respiratory tract. They might aspirate. It can make breathing more difficult. They can get an infection. And then, of course, smoking. Patients are much more vulnerable to developing pneumonia because they have reduced lung function. So they don't have the capacity to even cough and get up secretions properly. Their lung clearance becomes impaired, and maybe they've been subjected to lung irritants that have caused irreversible damage. So what assessments are we going to do? Some subjective assessments. We want to know what they've been exposed to. What kind of recent illnesses have they had? Did they have an upper respiratory tract a couple weeks ago, or the flu and it never resolved and now they have pneumonia? Do they live in a group home where you might see that atypical bacteria that's going to spread from from person to person? You want to assess their risk factors. So have they had any transplants recently? Do they have COPD and they take steroids? What pushed them at risk for developing it? Maybe they just had a knee replacement and they're not getting up out of bed. We have to make sure we're getting them up, but that's a risk factor. Have they had any recent surgeries or hospitalizations? Do they have decreased activity? Do they have a cough and sputum? And if they do, can they get it up? Do we need to give them something to help them expectorate it? And then are they having any kind of chest pain? So some assessment findings that we will see with patients that have pneumonia, they will have malaise, fevers, some of them abrupt onset and some of them very high, with chills. They will have their faces will be flushed. They're going to have diaphoresis. Dyspnea, so difficulty breathing. We can have dyspnea at rest and dyspnea with exertion, either one or both. They're going to have an increased respiratory rate, tachypnea. You're going to see use of accessory muscles. You might see nasal flaring. When we're talking about cough and sputum, it can be rust colored. They could have hemoptysis. They could be coughing up blood. It could be green. It could be yellow. It could be dark brown. They might have pleuritic chest pain. They might be tachycardic and dehydrated because they don't feel good. They're not drinking. Severe oxygenation changes. We're going to see changes in skin color. We're going to see that pallor. We're going to see that cyanosis. And then when we listen to those lung sounds, we're going to hear adventitious lung sounds. So we might hear crackles, wheezes. Sometimes we might not hear any lung sounds. They might be completely absent if that whole lung is compromised. When we check oxygenation levels, they're going to show decreased oxygenation levels. They probably will need oxygen, supplemental oxygen, and then they can have that purulent sputum, rust-colored or blood-tinged. I think we already said that. May or may not have that sputum, just depends. So what kind of labs and diagnostics are we going to do? Well, we're going to monitor that pulse oximetry. We're going to look for those low O2 levels. We will probably do a chest x-ray to look for consolidation, solidification, density of lung tissue. We're going to want to send that sputum off for culture and sensitivity if they're able to bring anything up. If we do a CBC, it could show elevated white blood cell count, which is an indicator of infection. we will send off blood cultures to be able to rule out organisms in the blood and to be able to rule out sepsis. We're going to do those ABGs because these patients are going to have hypoxemia. They're going to have a decreased PaO2. We're going to do serum electrolytes because maybe they're dehydrated. We want to be able to identify that and rehydrate them. And then we might want to do a CT scan depending on what else we think is going on with the lungs. So these patients are probably going to have respiratory acidosis. And those are your signs and symptoms of acidosis. So physical management, what are we going to do? We're going to get these patients hydrated. We want to give them, if we can, they don't have congestive heart failure or anything like that, as much fluid as we can safely to help thin out those secretions, loosen them up so they can cough them up, expectorate them, and get all that junk out. We also want to replace fluids that they're losing through diaphoresis if they're having a fever, and then that increased respiratory rate. Remember, we lose some water through our body through our respiratory rate. Well, these people are breathing faster, so they're losing more. So fluids, fever, and respiratory rate. We're going to give oxygen therapy. So we're going to appropriately give them the amount that they need to keep them oxygenated. We're going to think about weaning when it's necessary. We're going to monitor the skin for breakdown around the nose and the mouth, and then provide humidity if it's needed. We want to compromise, we want to protect their ability to be able to, I'm just drawing a complete blank. I can't think of any words. We want them to be on bed rest because we want to keep them, we want to preserve their strength. We don't want them to get up, walk around the room, get exhausted. If they don't have good oxygenation, they're not going to be able to walk around much. If they have pneumonia, they are pretty sick. They don't even really want to get out of the bed. It's okay to get them up and assist them to the chair. We do want to promote that, but we don't want to take them in the hallway, walk them for a long time. We want to preserve their energy. That's the word I was trying to look for. It's ideal that we keep them in a high Fowler's position because that's going to get the most air in, that good quality oxygen, but it could be contraindicated for some reason, or sometimes when you're just sick, you want to sleep and you want to lay down. So we have to be able to allow that too. So we want to suction our patients if they cannot get that stuff up themselves. If they can't get it out, maybe they cough it up and it's just stuck in their mouth. We want to make sure that we're assessing their need for suctioning every hour, suction as they need it, PRN. We do need an order from the doctor to do this. So you can have the doctor put in an order. Maybe they could benefit from chest physiotherapy. They're going to administer those breathing treatments and different medications and then do those exercises to help loosen that phlegm. We want to encourage deep breathing. So you can do cough and deep breathe. You can do the incentive spirometer because we know that's going to prevent that alveolar collapse. And then postural drainage. So this kind of goes with the chest physiotherapy where they put patients in ideal positions that'll help drain all that, all the mucus and all the secretions that they have, and then it helps them get it up. So medically or pharmacologically, we're going to give antibiotics. We're going to give bronchodilators to help open up their airways. We're going to give analgesics to help with any body aches or fevers that they have, antipyretics, cough expectorants, Mucinex, things like that, or that are going to thin those secretions so they can cough them up. Or if they don't have a productive cough, you could give them a suppressant if they are coughing too much and they can't sleep. So mucolytics, antitussives, and antimicrobials, antibiotics. So we know that the bronchodilators are given to help reduce those bronchospasms, and then it's going to reduce the irritation in their airway. So then we want to determine our clients' physical limitations and structure their activity to include periods of rest. So I feel like there's always so many things we have to do with our patients. You have to go for this test. We have to do labs. You have to get in the chair. You have to do this. But we also have to remember that these patients are sick, and we all know what it's like to be sick. So we do want to try and kind of clump our care together to provide those times so they can rest, because we know that rest actually helps heal our body. So rest is important. So what are some nursing diagnoses that we would see? Well, we might have ineffective airway clearance related to inflammation and the presence of secretions, impaired gas exchange related to decreased functional lung tissue, activity intolerance related to that imbalance between the oxygen supply and demand, risk for fluid volume deficit because of the inadequate intake of fluids, imbalanced nutrition, less than body requirements related to the loss of appetite, impaired oral mucous membrane because they're going to have dry mouth, because they're going to be mouth breathing. They might be congested and they might not be able to breathe through their nose. Also combined with that decreased fluid intake, ineffective thermoregulation related to that infectious process. So that would be their fever. And then risk for acute confusion. Risk factors would be underlying illness and hypoxia. So remember, if we don't have enough oxygenation, nothing gets that good, rich oxygenated blood, including our brain. It is an organ. So nursing management, we're going to make sure we are doing very, very thorough respiratory assessments at the beginning of your shift. You're going to be checking those lung sounds in everywhere, very detailed assessment of the chest. Remember, we said that as you start to become a nurse, that head to toe physical assessment that takes you 50 minutes now is probably going to take you 10. It's going to be very focused. If you have a patient that came in and he's 21 and he has, a blockage in his bowel, you're not going to be doing a very detailed respiratory assessment on it. But your patient that has pneumonia, you are. That's where you're going to focus around those lung sounds. You're going to listen thoroughly, listen long, compare sides, front to back, make sure you document it well. You're going to monitor their pulse ox, make sure their oxygenation status is good. You're going to want to do get your doctor to order ABGs if their pulse ox isn't good, so you can really get a good idea of what their oxygenation status is. If they're getting nebulizer treatments and other respiratory treatments like inhalers and things like that, make sure you go in after them and listen to those lung sounds again to compare to see if they had any improvement. Make sure you're doing those cough and sputum assessments. So if you have a patient that has pneumonia, you are going to ask them, do you have a cough? If so, is it productive or non-productive? What are you bringing up? Is it thick or thin? What color is it? Are you able to get it up or are you swallowing it back down? And then remember, try and get a sample if you can. You want to keep your patient at least in semi-Fowlers if they can tolerate it high Fowlers to really open up the lungs. And then we want to do that mental status assessment because they might not be getting proper oxygenation to the brain and they can be confused. So those adventitious lung sounds we were talking about, you might hear crackles. Sometimes they clear when they cough. If they do, we call that rhonchi. Wheezes are going to be heard during inspiration and expiration. They don't always have to be. They might just be one or the other, or they could be both. Sounds kind of like a hissing sound or a whistling. Rhonchi sometimes sounds like crackles. It's lower pitched and it can be heard in the trachea or the bronchi. Also will clear when they cough. That's how you know it's rhonchi. And then you could hear a friction rub. So these can be crackles. That grating sound, that's accurate. You would hear that on inspiration and inspiration, either one. So some breathing patterns that we might see. This is an important slide. You guys need to know these breathing patterns. So eupnea is normal breathing. That's what we're doing right now. If your patient has Kussmaul's, so we see Kussmaul's sometimes in patients that have diabetic ketoacidosis. These are very deep, very rapid respirations. This indicates that our body is trying to compensate for metabolic acidosis. So we are blowing off excess carbon dioxide in the system, or we see this sometimes after strenuous exercising. There is not going to be any There is not going to be any stopping between inhaling and exhaling. They're going to just be back to back. There's not going to be any break at all. These Shane Stokes, you remember these from your end of life lecture with Dr. McNamara. We commonly see these during end of life. It is cyclic breathing patterns with periods of apnea. So these will result from any condition that slows the blood flow to the brain. And it's going to, in turn, slow impulses to the respiratory center of the brain, and it's going to change their respiration. So it's cyclic breathing with periods of apnea. Biot's respirations are irregular respirations with irregular patterns of apnea, and there is no cyclic nature to it at all. So you guys need to know those. So patient learning needs. We want to teach our patients how they got pneumonia. How was it transmit? How did you get it? How can you give it to somebody else? So we want to tell them that it's airborne or that it's droplet, whatever it is that they have, that they can spread it by sneezing. They can spread it by coughing. It comes from droplets in the air. So we want to teach them to do good hand hygiene. We want to teach them to wear a mask when they're around other people, cover their sneeze, throw their tissues away. We want to let them know that it's caused by sometimes bacteria that's already in your nose or your throat that can spread to your lungs. If we want them to prevent something, we have to teach them how they are spreading it. So prevention, wash your hands, get vaccinated, get the flu and pneumonia, don't smoke cigarettes, have good healthy habits, have a good diet, exercise, practice good oral hygiene because the bacteria in your mouth can get into your lungs and cause pneumonia. Wear masks, and then post-stroke education. That's really important for our patients that had strokes because sometimes they have issues swallowing and they can aspirate and get aspiration pneumonia. We see that all the time in patients that have had strokes. So we want to educate about nutrition and how important hydration is so they don't get dehydrated and how it helps thin those secretions so they can get them up. And then we always want to talk about compliance with treatment. So if we give you an antibiotic, take the entire course of antibiotics as directed. Do not stop taking them even once you feel better because it can come back. So when we assess a patient's work of breathing, we can see dyspnea. So dyspnea is just that feeling of being unable to get enough air in, also shortness of breath. Dyspnea is caused whenever we have some kind of disturbance or change in our gas exchange. We can have dyspnea at rest, so the patient's not doing anything. They're sitting in the chair, they're sitting at bed, and they are visibly short of breath. Then we can have dyspnea on exertion. So when they're sitting there, they're completely fine, but whenever they perform any activity, then they become short of breath. We can have orthopnea. So this is when the patient lays down and they have short of breath. They're okay sitting up, but they can't tolerate laying down in the supine position. Then we have paroxysmal dyspnea. So this is sudden attacks of respiratory distress that wake the client after several hours of sleeping in a reclining position. Usually we see this in patients that have congestive heart failure, and it happens when they get pulmonary edema. And then sometimes it might hurt patients to breathe. They might complain that they have pain when they're breathing in. That's pretty common with pneumonia. And sometimes it's not anything more than just the fact that they've used so many accessory muscles because of the coughing that it hurts. It's the muscles that actually hurt. Cough and sputum. So, you know, we always want our patients to describe it as gross as it is. Sputum is not my thing. That's where I kind of freak out. Everybody has their thing they can't do. Sputum is not mine. What does it look like? Does it have an odor? What color is it? Is it thick? Is it thin? How often are you getting it up? How much are you getting up? Is there any blood? Is it brown? Is it yellow? Is it green? Those are all the things you can use to describe it. So cyanosis, so this is that bluish discoloration of our skin and our mucous membranes that we see when we have decreased oxygen. We see cyanosis when we have decreased arterial oxygenation. Sometimes if a patient has what's called a pulmonary shunt, this is when deoxygenated blood passes from the right side of the heart to the left without actually participating in that gas exchange that occurs in the pulmonary capillaries. We'll see cyanosis with that. If a patient has a cardiac shunt, this is when the pattern of blood flow in the heart deviates from that normal circuit of the circulatory system. That will cause cyanosis. If we have a patient that has decreased cardiac output. So our oxygenation is really fine, it's not a lung issue, but we're not getting enough blood out that's filled with oxygen to perfuse all of our organs. We'll see it in a cold environment, and then sometimes we see it with anxiety, and we can see it around the lips, around the nose, in the picture here on the fingers. So we want to be able to evaluate the effectiveness of care. So our clients, we want them to have respiratory assessments within normal limits. We want them to have adequate oxygenation. We want them to have adequate nutrition and fluid intake. So we're going to be monitoring those I's and O's. We want them to be compliant with their treatment. So using their inhalers, taking their antibiotics, keeping their oxygen on. And then we want to prevent reoccurrence. So finishing all those antibiotics and then educating them about how they got it and how they can prevent it. And then we want to have a lack of complications. So we don't want worse things to happen. We don't want them to get a pleural effusion. We don't want them to have hypoxemia. We definitely don't want respiratory failure, and we do not want them to die. Obviously, that can happen from respiratory failure. So we said that some of our stroke patients can have pneumonia from aspiration. So stroke patients are at big risk for this. This is why we don't have patients take anything by mouth before they have surgery, because some of the medicines we give them can cause them to vomit in their sleep, and then they can aspirate. So pneumonia from aspiration is the entrance of substances to the lower airway that produce inflammation. So it can be bacteria, gastric content, or food. It is very common in our upper lungs, and it's more common in the right side, mainly because that the bronchus on the right-hand side is the main bronchus. It's larger in diameter, so it makes it more susceptible for aspirated content to get in there. The overall effect of aspiration pneumonia is hypoxemia. It's usually acute, so it's an acute onset of dyspnea. They may have a low-grade fever, and then usually we're going to treat it with an antibiotic, and the antibiotic we usually use is clindamycin. So what are the causes of aspiration pneumonia? So we talked about swallowing disorders. We see a lot of swallowing disorders with patients who have had strokes. If patients are nauseated and they vomit, they can always aspirate on their vomit. If they have a decreased level of consciousness and we're feeding them and they're pocketing their food and then later it just goes down their throat and they choke on it. If they can't tolerate liquids, they can aspirate on it. If they have a seizure and they vomit, they could aspirate on that. And then there can always be silent aspiration, where sometimes the patient swallows something, they aspirate it, but it's silent. You're not going to see that coughing. That's called silent aspiration. So how do we prevent it? So we always want to be an advocate for our patients, especially our stroke patients. So we want to know how they take their meds. Do they have any special diet? If they are on like thin liquids or chopped diets, you want to make sure you have signs on the door so anybody that comes in besides you will know not to give them certain things. You can do swallow evals on your patients at the bedside that are being ruled out for a stroke. You can do the swallow eval. You can have the doctor put an order in for speech to come and do it. You can check their gag reflex. Med-surg nurses don't usually do that. That's something I've never done that as a nurse. They usually do that up in the ICU. You want to promote, you want them to be in that high Fowler's position when you're feeding them. You don't want them to be laying flat. So our tube feedings, we always want to make sure when we give our patients tube feedings that we keep the head of the bed elevated. Dietary changes, we want to be aware of those soft diets or liquids. Can they tolerate them? we want to check the placement of that G tube. So if we put an NG tube in, we want to make sure we get X-ray confirmation before we use it. And patients with tracheostomies, we want to keep that cuff inflated during and after meals so that nothing can get in that area and they can't choke on it. So tracheostomies, they either come with a inflated and cuff or they don't. I've never had to actually inflate it during a meal or not. I guess in some circumstances, I guess for testing, you guys should know that, but that's not something that I've ever done. They usually either have a cuffed one, and if they do, it stays blown up, it's cuffed, and if they don't have it, then we don't inflate it. All right, so next we're going to talk about tuberculosis. So this is bacterial infection that's caused by Mycobacterium tuberculosis, or they also call it acid-fast bacillus. So once the bacteria is inside the lung, the body encases the TB bacillus with collagen and other cells. This is going to appear as gontuberculate on a chest X-ray. You'll be able to see it. When we talk about tuberculosis, we're going to classify it as latent or active. We're going to talk more about that. It is an airborne infection. If your patient has it and they're in a hospital, they need to be on airborne precautions in a negative pressure room. It is you can give it to other people by inhalation of these droplets. It can be coughing, sneezing, or spitting. Only a very small percentage of people infected with TB actually develop an active form of the infection. So the TB bacillus can actually lie dormant for many years in your body before it actually produces the disease. It primarily affects the lungs, but in rare instances, it could affect the kidneys and other organs. It is the second leading cause of death from a single infectious agent. And the new cases of TB, we are actually seeing them decline, which is a good thing. So the death rate dropped 47% between 2000 and 2014, which is really good. And the World Health Organization had a goal of ending tuberculosis epidemic by the year 2030. And we've seen an increase, obviously a decrease since 2000. So pathophysiology, it's a bacterial infectious disease caused by Mycobacterium tuberculosis. It's transmitted by inhalations of those droplets, coughing, sneezing, and spitting. Factors that predispose a patient to the development of tuberculosis are inadequate health care. So they might not have access to it. They might not be able to afford it. It might not be something where, maybe they live far away from it. It's a combination of factors, but not being able to get that health care. Malnutrition, not having access to food, not having money to buy food, not having that proper nutrition. And then overcrowding and poor housing. Those are all risk factors. So our classifications, we have latent and then we have active disease. Latent bacteria are present, but their bodies prevent the bacteria from multiplying. These patients have no signs or symptoms, are not ill, and are not contagious. So you guys need to know this. Active disease is when the TB bacteria become active, and if they're able, they begin to multiply. These patients are sick and they're contagious. So active disease, they're sick and contagious. Latent, no signs, no symptoms, they're not ill and they're not contagious. So the classification of TB is based on the client's history, maybe where they lived, have they gone out of the country, what have they done, what kind of other lung issues have they had, what are we seeing on our physical examination right now, how are they presenting. We will do a skin test, which we'll talk about more on the next couple of slides. Combined with an X-ray and some other microbiologic tests. So we combine all these things to make a diagnosis. So TB is actually, we can classify it as latent or active, and then we can also characterize it by stages. So we have early infection, latency, and secondary. So early infection is our primary TB. Secondary is going to be the potential for reoccurrence after the primary disease. The bacilli may remain dormant for many years and then reactivate, producing the clinical symptoms of TB. So, risk factors. Frequent and close contact with an untreated individual. So someone that has it, but they haven't been treated for it. That puts you at risk. Doesn't mean that you'll get it, but it does put you at risk. Low socioeconomic status and homelessness. If you are immunocompromised, if you have HIV, if you're taking chemotherapy, if you have kidney disease or you've had any kind of organ transplant and you're on anti-rejection medicine, patients that have diabetes, patients that have Crohn's disease, if a patient has been outside of the United States to areas where TB is an epidemic, immigration, especially when people come from Mexico, the Philippines, Vietnam, China, Japan, and the Eastern Mediterranean countries, we see outbreaks of TB there. And then when we talk about areas that are poorly ventilated or crowded environments, so long-term care facilities, prisons, advanced age makes you more susceptible because of all the changes in the lungs. Substance abuse also puts you at risk. And then healthcare occupation that involves performance of high-risk activities. So these are your respiratory therapists. So when they're giving respiratory treatments, they're doing suctioning, coughing procedures, those are all high-risk occupations. So when we talk about the early infection, so the tuberculosis bacilli is inhaled. Once it's inhaled, it passes through the bronchial system and it implants on those bronchioles or the alveoli. Initially, the host, which is the person, has no resistance to this infection. What happens is the phagocytes move out, they release the neutrophils and the macrophages, they go to that infection, they try and engulf it. What happens is they continue to multiply. They're spread through the lymphatic channels to the main lymph nodes, and subsequently it goes out into the circulating blood, and then it can move to distant organs. Eventually, the cellular immune response limits further multiplication, and then we see dissemination of the bacilli. It's quite a process. Immune activation usually occurs with a full response within 2 weeks. Characteristic tissue reaction comes in the formation of a granuloma, which is referred to a Gone tubercle. Lymphocytes are going to surround that Gone tubercle around of which the central portion is going to undergo like a necrosis period. It's going to become necrotic. It's going to have, if you look at it on an x-ray, it's going to have kind of like a cheesy appearance. It might liquefy, it's going to slough off. It's going to produce a cavity in that connecting bronchus that you'll be able to see on an x-ray. It could also enter the tracheobronchial system, promoting that transmission of that infectious particle. Finally, you're going to have healing of that primary lesion. It's going to heal through resolution, fibrosis, and then eventually calcification. The granulation tissue of that primary lesion is going to become more fibrous, and then it's going to create a scar. This is referred to as that Gone complex, and we can actually see this on the x-ray. So then we have the latent period. So this is after the incision, the lesion heals, the infection then enters into that latent period. This can persist for weeks, years, even an entire lifetime without ever again producing any clinical symptoms. If the immune response has been adequate, the affected person will eventually if it has been inadequate, I'm sorry, if the immune response has been inadequate, eventually the person will develop the clinical disease and they'll get TB. Clients that are obviously at particular risk, diabetes, chemotherapy, long-term steroids, HIV, all the immunocompromised people. And we said earlier, only a small percentage of those infected with TB actually develop clinical symptoms. So now we have active tuberculosis. This is also called secondary tuberculosis. So secondary tuberculosis usually involves reactivation of this initial infection. So the person has already had an immune response. They had lesions that form that stay in the lungs. Usually the course goes like I have it on the slide. You have that acute local inflammation, you get that necrosis, the infected lung tissue becomes ulcerated. Those tubercles come together, they cluster together, they become surrounded by inflammation. Exudate is going to fill around all those little alveoli. The client is going to develop what they call bronchopneumonia. The TB tissue becomes caseous and ulcerated. It's going to form a cavity again. Those ulcerations are going to heal. It's going to leave behind that scar tissue around the cavity, and then the pleura are going to thicken and retract. You will be able to see this on our x-ray. So the course of TB is a cyclic process. It's going to involve that inflammation, that bronchopneumonia, that ulceration, that cavitation, and then eventually that scarring. That's the process. It's going to gradually spread throughout the lung fields into the respiratory structures of other organs through the lymph system. So remember we said it could affect your kidneys and your liver in rare instances. You will see periods of exacerbation followed by periods of remission with this secondary TB. So assessment findings, signs, and symptoms. So in early stages, you're going to have very non-specific signs and symptoms. And infected people may be asymptomatic until the disease is advanced. So fatigue, malaise, these are all things we can write off as just having a bad day at work or not getting enough sleep. As it starts to advance, they're going to have fevers, increased temperatures, and night sweats at night, like soaking the bed night sweats. During the day, particularly in the late afternoon, you're going to have a low-grade fever, and it's going to continue into the night. You're going to have those night sweats. You're going to be dehydrated, right, because of that increased temperature and the sweat. Loss of appetite, weight loss, productive, persistent cough. It's going to last longer than 3 weeks, and they're going to be short of breath. They're going to have hemoptysis. So they're going to lose weight. They're going to have a bloody cough. They're going to cough up blood, that low-grade fever, night sweats. When you hear that, that's the first thing you should think, tuberculosis. They're going to have adventitious lung sounds. They might have chest pain if that infection spreads out into the pleura. And then they're going to have they complain of a weak neck, and they're going to be what we call wasting, because they're going to be losing a lot of weight. It's going to be noticeable. So remember, the early stages, they don't really have a lot of symptoms at first. It can be very non-specific or asymptomatic. So what kind of laboratory and diagnostic tests do we do? We can do a PPD, which is a tuberculin skin test. What we do is we take a needle, it's on the next slide here, filled with this medication. We go right just barely under the skin. We inject the fluid. You're going to see this little bubble come up. It's going to go just into the dermis, not very far. That little bubble is going to come up. Usually what the doctor's office will do is they'll take a pen or a marking pen for skin, and they'll put a circle around that area so that as the next 24 to 48 hours go by, you remember where you put it. And then you're going to be looking for some induration in the skin or some redness. So down at the bottom here shows positive. So if you have 5 to 9 millimeters, if it's raised or red, that's positive. 10 to 14, greater than 5 millimeters of induration is considered positive. And these are just the different variations of that positive. It does have to be read by, so a positive is greater than 5 mm's to 10 mm's. This is indicative of an exposure to the tuberculosis. Once you have that done, it has to be read within 48 to 72 hours. A nurse can read it and sign off on the paper. It is that intradermal injection of the extract. Previous TB vaccines can cause a false positive. So if your patient says, I've been vaccinated against TB, and they get a positive, then you know that's why. If you want to read in depth about performing that test, you can on page 328. Box 21-1 goes into a lot of detail. We're also going to do a chest x-ray. That chest x-ray is going to show calcification of an old disease or active disease. And then we can also do something called the quantiferon TB Gold. It's also called IGRA. It stands for interferon gamma release assays. So we just call them IGRAs. So these are blood tests that we use to detect the release of this interferon gamma. It's diagnostic for an infection, whether it's latent or active. And usually it takes about 24 hours to get the results. Already seen that. So we can also do an acid-fast bacillus test, an AFB. We would need to have 3 consecutive positive tests in order to say that the patient has tuberculosis. Not 2, not 1. You have to have 3 consecutive positive tests. The positive acid-fast test does suggest active infection. We can also look at their white blood cell count, their sedimentation rate. These are going to be indicative of infection, and then inflammation in the body. We can do a CT of the lungs, an MRI of the lungs, especially if they have a positive test that comes back. The MRI is always more detailed. We can do a bronchoscopy, so we can go in there and take a culture to see what's in there. They can do that gastric lavage or a gastric aspiration to determine if there's any of that tuberculosis bacilli in there. And then we could also send their sputum out for culture sensitivity, microscopic examination. If you want to send that off, the best, you want to send 3 of them, and you want to do early morning samples are the best. Medical management. So this is the list of the medications that we're going to give. So isoniazid, also called INH, it's a combination medicine with vitamin B6. It is an antibacterial, and it inhibits growth of that myobacterial, and it prevents the synthesis of the mycolic acid in the cell wall. We can also give them rifampin, also a bacteriostatic and a bacterial antibiotic that is going to inhibit that DNA activity in certain cells. We can give pyrazinamide, PZA, which is a bacteriostatic and a bactericidal. They're not really sure exactly what the mechanism of action is in that. We can give EMB, which is a bacteriostatic, and it works by suppressing that RNA synthesis. And then we can give streptomycin, which is not widely used now. It's an aminoglycoside antibiotic, and it potentiates the efficiency of macrophages during phagocytosis. So the take home of these medications is that it's very hard for patients to be compliant. So this is a 6 to 12 month regimen. This isn't just something that they take for 7 days. They are taking this for a long time, even up to 2 years with some types of TB that are multiple resistant. So it's hard for these patients to stay compliant and take this medication all the time. It's hard for them to tolerate the side effects of this medication sometimes. So these people need a lot of education. You want to send off sputum samples every 2 weeks to monitor for the effectiveness of the medication. Clients are not considered infectious after they have 3 consecutive negative sputum cultures, and then they can return to their employment. So 3 negative sputum cultures, and they need to send off samples every 2 to 4 weeks. Sometimes, depending on how severe the infection is, they might have to do surgical interventions. So if the disease is heavily located in one area, they can do a segmental resection. They can just remove a lobe of the lung. They might have to do a wedge resection, which is where they remove just a wedge of the actual diseased tissue. They don't have to remove the whole lobe. If the disease is in a larger area, they might have to do a lobectomy, which is a removal of a lobe, or a pneumonectomy, which is removal of the entire lobe. That would be in extreme circumstances. Amy, you look miserable. You're holding your head. It's like too much information, isn't it?
No, it's okay.
I know, it's really hard. This is a lot of information. Nursing diagnoses. Ineffective airway clearance related to pain, because pain with coughing might be inability to cough or abnormal respirations. You might see ineffective breathing pattern related to fatigue, decreased energy. We want to encourage our clients to drink 3 to 4 liters a day. We can offer that humidified or heated oxygen therapy. I've never given heated oxygen therapy. It's not something I've ever seen. I guess it exists. We want to encourage those deep breathing and coughing every 2 hours while awake, or use those instead of spirometers. Place the client in a semi-Fowler or a high Fowler's position. Another nursing diagnosis would be readiness for advanced to enhance health management. So taking those medications according to the prescribed protocol so that we can prevent and treat any recurrences. We want to provide emotional support for these patients, because they're very sick, and it's also just a very long road to recovery. So they need a lot of emotional support. And then we know that they can have anorexia and weight loss, so imbalanced nutrition, less than body requirements. We want to encourage good fluid intake, a well-balanced diet with an adequate caloric intake, encourage foods that are rich in protein, iron, vitamin C, and B. We might see acute pain related to chest expansion secondary to lung infection or inflammation in the lungs. So we can administer analgesics as indicated, instruct the client different splinting techniques when they're coughing to try and hold their chest. It helps minimize the pain. Activity intolerance related to general weakness, respiratory difficulties, that fever that they're going to have, and just the overall severity of the illness. So we're going to prioritize necessary tasks. We're only going to have them do what's absolutely necessary. We're going to eliminate non-essential tasks. So this might mean if you have a woman in the bathroom is a little bit across the room, maybe you're going to get a bedside commode. Put the bedside commode next to the bed so the patient doesn't have to walk as far, and you can preserve some of their energy. If it's for a man, you can just encourage that he use a urinal, stand up at the side of the bed. If they want to get cleaned up, you can have them sit at the end of the bed. You can help them get cleaned up, set them up with their their washcloths, their bin, warm water, all that stuff. We still want to encourage active range of motion exercise while they're in the bed. We want to keep everything moving. And then we want to promote adequate nutrition. Risk for infection, insufficient knowledge regarding avoidance of exposure to pathogens. So wearing an N95 HEPA filter or a powered air purifying respirator when caring for a client that is hospitalized with TB. In the hospital setting, they're usually in negative pressure rooms. Everybody wears an N95 now. So you would do that. There's the next thing, place that client in a negative airflow room, implement those airborne precautions, and then have the client wear a surgical mask if they're leaving the room and they're being transported to another department. They always have to have a mask on. So we want to advocate for them to follow that medication regimen. This is really important. We want them to take all of their medications exactly as prescribed. We want to observe the interval, the time between each dose. We want to tell them not to skip doses or take more than the prescribed amount. We have to keep a therapeutic level of these medications in their system. They need to complete the entire course of drug therapy in order to control this infection. Continuous therapy is essential because any lapse in the prescribed medication can result in that reactivation of the infection. Nutrition, we want to make sure that they have a balanced diet with ample protein and calories that are going to promote healing and help maintain their weight. Fluids, 3 to 4 liters a day. The amount is going to keep them hydrated because they have that fever. And then it's also going to liquefy and thin those secretions and facilitate help them expectorate them and get them up. So with regards to compliance with treatment, they are going to need regular visits to their physician or to the clinic for necessary assessments of response to treatment. So they're going to be tested. They're going to be testing their sputum, making sure that the therapy regimen that they're on is working. If not, they might have to make changes to it. And then we obviously want to prevent and control the spread of that infection. So we want to teach the patient how to do that. Wash the hands each time they cough. Wear a mask in a public area. Throw your tissues away. Cover your cough. All that good stuff. So when we evaluate our patients with TB, we want to see some of the signs and symptoms subside. Remember, this is a long process, so we probably aren't going to see all of them, but we want to see things going in the right direction. We're going to see improved oxygenation. Maybe they were on 4 liters before, and now they're doing their activities of daily living, and they only need 2, or maybe they don't need any oxygen. We're going to see those sputums come back negative. That respiratory assessment's going to improve. It's going to start going back to normal. We're going to hear less and less advantageous lung sounds. The patient's going to be compliant with treatment, and we want to avoid any complications. So we don't want a pneumothorax to develop, which is where your lung collapses. We don't want to have a surgical lobectomy, and we certainly don't want to have any respiratory failure because we know that that can lead to death. So now we're going to talk about pneumothorax. So this is the presence of air or gas in the pleural space that causes a lung collapse. This occurs when the parietal or the visceral pleural become breached somehow, and the pleural space is exposed to positive atmospheric pressure. It prevents the lung from inflating, and it can cause a partial collapse of the lung, or we can see a complete collapse of the lung. Symptoms that so we're going to talk about, there's a couple of different types of pneumothoraxes. So we have what's called a spontaneous or a simple. So this can occur just for no apparent reason. There doesn't even have to be any type of trauma. It can be when we have like what they call an air bleb or an air blister on the surface of the lung ruptures, and it causes that atmospheric air to come into the pleural cavity, and then it causes that portion of the lung, wherever that bleb or that blister was, to collapse. It is associated with diffuse interstitial lung disease and severe emphysema. That's when we tend to see these. An open pneumothorax occurs when you have a wound in the chest wall that is large enough to allow air to pass freely in and out of that thoracic cavity with each respiration. The lung is going to collapse, and the mediastinum, which is that heart and the great vessels, will shift towards the uninjured side with each inspiration and the opposite direction with expiration. So Sometimes we do thoracotomies where we go in, the doctors go in and they do a surgical opening in the chest wall. We do these to promote drainage from the chest if there's some kind of fluid in there. Sometimes we will insert chest tubes, so that would be called a tube thoracotomy. We put these in to help remove air. We can help remove fluid, sometimes during a pre-operative period or afterwards. Sometimes we do it if we have to do a biopsy, if we think there's a lesion in there and we want to test it to see if it's malignant. We can remove tumors. We can repair trauma. Sometimes we do it if we're doing a thoracentesis. So remember we said a thoracentesis is that procedure where we go in with the needle and the syringe and we remove blood, fluid, or air from the chest. And then sometimes with placement of IV catheters. So a traumatic pneumothorax, this is going to be caused by penetration or a non-penetrating injury. So some type of injury occurs or some type of penetration occurs, and it's going to allow atmospheric air to enter that pleural space. So things that you would want to, where you would see these would be any kind of blunt trauma, fractured ribs. If you're in a car accident, if you have a fall and your ribs become fractured, gunshot wounds, stab wounds, these are penetrating chest or abdominal trauma. Any kind of invasive procedure, thoracentesis, a transbronchial lung biopsy. If we put in a subclavian line, that's why we always do x-rays after we do these procedures to make sure that the lung is still intact and we haven't caused a pneumothorax. These are usually accompanied by a hemothorax, which is going to be a collection of blood that develops in that pleural space, or a hemopneumothorax, which would be a combination of blood and air. So the hemo is just blood in the pleural space. A hemopneumothorax is blood and air. Then we have a tension pneumothorax. So this is going to occur when air enters the pleural space during inspiration through a one-way valve and is not going to be able to exit when we expire. So the air is going to become trapped. When that air becomes trapped, it's going to put pressure on the heart and the lungs. All that pressure is going to increase. It's going to compress our blood vessels. It's going to start to limit our venous return, and then we're going to have a decreased cardiac output. This is a medical emergency. Death can result if not treated immediately. You guys need to know what a tension pneumothorax is. This produces compression of then the unaffected lung. You're going to have a shifting of the mediastinum to the other side of the chest, and then it's going to impair your circulation. We call that a mediastinal shift. So pertinent risk factors for these lung issues. Young age. So we know that children that are young partake in risky behaviors. They drive mopeds, four-wheelers, they climb trees, they have injuries. They're just busy little people and they're risk takers. So they can have any kind of injury. Older adult clients, because they have that decreased pulmonary reserve, because they have decreased lung elasticity and that the alveoli thicken. So COPD puts them at risk. Any kind of blunt chest trauma. So car accidents, sometimes we see it in sports, football, things like that. Penetrating chest wounds, stab wounds, gunshots. If a patient has a chest tube and it becomes occluded or it gets clamped for some reason, that can cause a pneumothorax. And then any kind of invasive thoracic procedure that we're doing. So a thoracotomy, a thoracentesis. Anytime we have those things, we want to make sure a central line that we do an x-ray when we're done to make sure we haven't caused any damage. So our nursing assessment and our clinical manifestation. So it's going to really depend, what we see is going to depend on the cause and the size. So signs of respiratory distress, we're going to see tachypnea, we're going to see tachycardia. The patient can have hypoxia, they might have cyanosis, dyspnea, and then you're going to see use of those accessory muscles. You may have reduced or absent breath sounds on that affected side. Very, very common to have absent breath sounds. If you're doing percussion, which we're not, you might have hyperresonance due to that trapped air in there because of that pneumothorax. If you have a hemothorax, you're going to have dull percussion. Guys don't need to know that. You could get what's called a subcutaneous emphysema. So this is where air accumulates in the subcutaneous tissue. You could have hypoxemia and cyanosis. The patients might complain of sudden pleuritic pain on that affected side, like it just comes automatically. And they're going to call you and say, oh my God, I'm having such bad pain. You might, when you look at them, their chest wall may not be symmetric when they're breathing in and out because that lung is collapsed. Diminished to absent breath sounds, hypotension because we're going to have that decreased cardiac output, tachycardia because we're trying to pump more blood because of our blood pressure being low, apprehension, anxiety because of the hypoxemia. And then we're going to see that tracheal deviation to the unaffected side, which is that tension pneumothorax. So you can see that tracheal deviation right here in the patient's neck. You see how it's going off to the side. So that deviation is always going to go to the unaffected side. You guys need to know that. So this is the esophagus, the heart, and the great vessels. They all deviate to the unaffected side. That is your tension pneumothorax. You guys need to know that. So what kind of lab and diagnostic tests can we do? We want to monitor their pulse ox. We can either do it through a continuous pulse ox that we put on their finger and it gets hooked up to their telemetry, or we can just use the one on the vital sign machine. We can do those ABGs to really get a concrete, definitive finding of what their oxygenation status is. We can do a chest x-ray, which is going to show that that lung is collapsed, a CT scan, an EKG, and then we want to have them use an incentive spirometer. So how do we medically manage pneumothoraxes? We want to monitor their pain. It's very painful, but we also want to monitor their respirations. How quick are they breathing? We don't want to decrease their respirations by giving them pain medicines. We have to be careful. We're going to want to control their anxiety because it's related to that inability to breathe. So they panic, which causes them to breathe, even more and have even more anxiety. It's kind of like a cyclic circle. So we might have to give them pain medicine. We might have to give them anxiety medicine. We're going to teach them respiratory exercises. So we want them to practice deep breathing. We want them to use incentive spirometer, and we want them to cough to help expand the alveoli and then prevent atelectasis. Usually we will have to put a chest tube in. This is not done by us, it's done by the doctor, but the purpose is to withdraw air from around the lung or sometimes fluid. So the doctor will go in, they use a very firm plastic tube that has drainage holes in it. It goes in the proximal end that is inserted into the pleural space. Once they get it in there where it's secure, they secure it with tape and sutures. It's not secured very well. It's very, very easy to pull out. I've seen patients that try and get up out of bed and they don't have their chest tube with them and they pull it out. So it's just sutured in there with a little bit of tape. So we have to be very, very careful. They do then cover it with an airtight dressing. It's usually some type of gauze and tape. And then that tube gets attached to a drainage system that may or may not be attached to suction. It all depends on what the doctor orders. So when we manage our chest tubes, so these are inserted into that pleural space. Like I said, we can drain air, we can drain fluid, we can drain blood. We use it to help reestablish that negative pressure and reinflate that lung because there's negative pressure in the lung. When you get that hole, when you get that atmospheric pressure, that's when it changes. That's when it deflates. It's going to facilitate lung expansion. All these typos, I apologize. And it's going to help restore that normal intrapleural pressure. So we want to use a chest tube when there's negative pressure in the pleural space. Sometimes we use it if there's been some kind of thoracic surgery and we are draining fluid or blood or air. If there's been some kind of trauma to the chest, again, we're doing drainage of fluid or blood. If they have pleural effusions, we want to get all that liquid out. And then, of course, if they have a pneumothorax. So nursing management for the chest tube. So we're responsible for managing it and assessing it to make sure that it's functioning properly. So whenever we have a patient with a chest tube, we always want to make sure that the chest tube stays on a flat, level surface. Just like the Foley, it needs to be below the chest level, and we want to keep that tubing free from any kinks. Usually it sits right on the floor next to the patient. It always has to remain a closed system, and it has to be below the chest level. You guys need to know how to manage your chest tubes. You're going to see this on your test. You are going to monitor the chest tube for drainage. Bloody drainage is normal, but it should not be bright red or copious. It could be at first. When you first put it in, that is something expected that you'll see because it just went in. But as the time progresses, it should get a little bit darker. When you go in and you are taking over your shift as a nurse, and that chest tube is already there, what I do is I take my Sharpie right there during bedside report. I get down on the floor, I make sure I'm level with it, and I take my Sharpie and I mark on there the level where it is at the start of my shift. So I know how much it's putting out throughout the day, and it'll be easy for me to document my I's and O's. When you first set up your chest tube, you should have some fluctuation of fluid in what we call the water seal chamber. This is initially present each time the patient breathes in and out. Eventually, as that lung re-expands, that's going to stop. You're not going to see that anymore. When we see bubbling in the water, we see this in the seal chamber very, very early in the postoperative period. If it is excessive, because it should stop after we initially put it in, the nurse is going to check for leaks. If you check for leaks, you check all the connectors between the chest and that drainage system, where the drain enters the bottle, and your suction tubing if it's hooked to suction. If there's no apparent leaks, this is an emergency and you need to notify the doctor right away. That means there's some kind of air somewhere that we don't want. So you see bubbling in that chest tube, you're going to check for leaks. If you don't find any leaks, you're going to notify the physician. You need to know that. Okay, I just gave you all the information you need to know. You should be writing that down. Right. Get your pen. The drainage tube must remain patent because we have to get that fluid out. We have to get that air out. So we need to make sure it's patent. We don't want to clamp it unless the doctor tells us to. So sometimes we hook our patients up to it. They put it to continuous suction. They might put it to intermittent suction. They might just put it to gravity drain. As the days go by and the fluid levels decrease, this is why your strict I's and O's are so important. The doctor's going to say, Trish, how much did Mrs. Jones put out today? She only had 100 cc's. Great. She had 400 yesterday, 100 today. We're going to pull that tube. If we're not properly documenting our I's and O's, we could pull that tube when she still has fluid in there, which can cause the pneumothorax to reoccur again. So this is another reason why our strict I's and O's are so important. Clogging of that catheter, either with clots, I can't talk, I've talked for too long, clots, or kinking can cause the drainage to stop. If the drainage stops, the lung is not going to be able to expand. Then you're going to see that heart and those great vessels shift, right? That mediastinal shift to the opposite unaffected side. The nurse must be alert to the proper functioning of the drainage system. You're always going to check your connections. Always check your orders. Should it be intermittent suction? Should it be gravity, continuous? Did the doctor order you to clamp it? Because what we'll do is if you progressively go along and it's day 5 and she's only had maybe 100 urine output yesterday, the doctor's going to say, let's clamp it. We're going to do like a trial run. You'll clamp it. If the patient doesn't complain of any pain, that means she probably doesn't have any more air or any more fluid. So then they'll monitor that for like 6 or 7 hours, and then they'll say, okay, she's fine. She hasn't had any problems. Let's pull the tube. If you clamp it and the patient starts complaining of pain, well, something else is going on. They probably need to open it back up again and facilitate more drainage of air or that fluid. So we as nurses need to make sure that it's properly functioning, and then we need to correct any issues that we see. Observe for abnormalities. So remember we talked about that subcutaneous emphysema. This is when air gets between those subcutaneous layers, and what will happen is you'll actually see where the tube comes out of the skin, that area around it will crack. We should be checking this dressing on a regular basis. It should be, sometimes they don't put orders in. I feel like sometimes if doctors don't put orders in for everything, some nurses just don't know what to do. This is a dressing. We have fluid coming out of this area. We always want to check that area because we want to check the skin integrity. We want to make sure that there's no infection there. So at least once a shift, you should be peeling that dressing back and looking. If there's any drainage on there, you should be changing it, taping it back up again. It's usually just like an abdominal pad or some type of a gauze. You can replace that, put new dressing on it, make sure there's no signs of infection there. Nurse management, we want to make sure that our patients are at a 90-degree angle for the most part. We want them in that high Fowler's position. We're going to be auscultating those heart sounds and lung sounds and looking at their vitals every 4 hours. We're going to assess their color, their neurological status, their heart rate and rhythm, respiratory rate, depth. We're going to monitor that dressing for any drainage. Make sure it's firmly adhered to the skin, inspect the skin around it, right? Because if we get that subcutaneous emphysema, we're going to see that cracked area. Make sure that if they need oxygen, we're giving them oxygen. Monitor those I&Os every 4 hours. At your shift change, you should be marking it with your Sharpie. When you give bedside report that night, you should bring that next nurse in and say, this is where I started this morning. He had 500 output. This is, you're coming in now. Now it's up to 1,200. This is how much he's had at the end of the shift. And then make sure you document that in the computer, because the doctor is going to base his management of this tube off of your documentation. For me, I don't let techs or CNAs monitor this output. They certainly can, but I like to have my eyes on it. I want to know exactly how much this is because I know how important it is. So it's just something I do myself. It is something you can delegate, but you are ultimately responsible for making sure that it happens. Note the level at the start and the end of shift. Instruct the client to do those deep breath exercises to promote that good lung expansion. Deep breathing and sinus barometer. It's going to prevent that atelectasis. Give any medications that we're giving for pain. Benzodiazepines or sedatives, we're going to give them for their anxiety to help calm them down. And then we can give some opioid agonists. We can give morphine or fentanyl or just Motrin. We don't always have to go right to morphine or fentanyl. A lot of people don't have a lot of pain with these. Less is better. So this is what the actual chest tube looks like. They're a little bit different in each facility, depending on what brand they use. They're pretty small. You can carry them. They usually have a handle at the top to carry them if you have to go to the bathroom. Emerson pumps, I've never really seen one of them. Those are glass bottles. I've only ever seen the plastic ones. Pleurovac, they're drainage collection systems. They have a drainage collection chamber. It comes with the patient. There is that water seal chamber. There's also a suction chamber attached to the source of that you can attach to your suction on the wall if the doctor orders it. The thing you want to think about is if they're getting up to go to the bathroom, you want to make sure that they have enough tubing so that they can walk to the bathroom. You don't ever want to disconnect them from this. So sometimes you have to put two tubings together so that it's long enough to go to the bathroom. This is another type of, this is the kind we actually use where I work. This is the atrium. So right here, the doctor's going to tell you what number he wants it on. Usually they come back from surgery with these. They're already set up. And then there's orders in the computer. So you verify them in the computer. This is the water chamber. And this is where you would document. This is your output. So 10, 20, 100, 1200, up to 2000. You would just take your little Sharpie on there and mark it wherever you see it at the beginning and the end of your shift. And right here at the bottom, this is that clamp. So if the doctor says clamp it, let's do a trial run, that's the clamp you would use. So chest tube placement, we always want to know where it is. Is it in the left or the right? It's going to done obviously by a physician. What you should chart, what the nurse should chart before the procedure, you should make sure that there's orders in the computer for the chest tube. You should set up the Pleurovac. If you're using one, I've never actually used that. I make sure that the room has suction. I make sure that that it has working suction on the wall, and I make sure that they have tubing, and I always bring extra tubing just in case. This is not going to be a sterile procedure. When you see a tube that's placed higher in the chest, that's usually because they're draining air. Usually it is a little bit lower in the lung if we're doing fluid. So upper is air, lower in the lung is fluid.
Did you say it is or is not a sterile procedure?
It is. Did I say is not?
I think so, but I don't.
Sorry, I've been talking
okay.
too long. It is a sterile procedure. Yes, we're going right into the lungs. I apologize if I said it is not. It is a sterile procedure. All right, so maintenance of the chest tube. So we talked about keeping it low, unkinked, level on the floor, checking the drainage. Some other things that you would want to have in the room, you should have 2 rubber tipped clamps and additional dressing material at the blood side. I'm really tired. At the bedside, 2 rubber tipped clamps and additional dressing material. If you have a break in the line or the tubing or the system and you happen to have a leak, then the nurse is going to be able to use them clamps to clamp the tube immediately, and then you're going to notify the physician. So you don't want to have to need these things and not have them at the bedside. So it's, you know, you're going to get your patient back from IR, you know he's coming back with a chest tube, make sure you have everything in the room. You also want to keep some petroleum jelly. If for some reason that chest tube comes dislodged, we automatically take petroleum jelly and we put it over top of that site where the chest tube came. We put that dressing back on top and we call the doctor right away. You always want to keep a bottle of sterile water in the room, those hemostat clamps, and that occlusive dressing at the bedside. The dressing, just in case you have to reinforce it in case there's any blood or fluid coming out or if you need to change it. And then that sterile water, if you're setting up the chest tube, I've seen chest tubes put in at the bedside. It has happened. Not often. Usually they come back with them, but you need that sterile water to put in the chest tube if you're initiating it at the bedside. So the drainage system has that water seal that is that operates as a one-way valve. It is
Ms. Davis, if we clamp the tube in, I thought that was dangerous. I thought we were supposed to.
Well, you're only going to clamp it if the doctor tells you to, but if you have a break or a leak somewhere, then you have to do it in an emergency situation.
Okay.
Yes, and then notify the doctor. I've never had to do that, by the way. Never had that done. I mean, I'm sure it could happen, but I've never seen it, and I've taken care of a lot of chest tubes. Where was I? The drainage system has that water seal. It's going to operate as a one-way valve. So you have to have a required amount of saline that is added into that water chamber while ensuring that the end of the patient tube of their tubing remains in the fluid. Usually that's all set up. That happens in IR, and it's all done when your patient comes to you. You never want to clamp the tube if the patient leaves the unit for a test or moves away from the bed. So you need to make sure that they have extra tubing so that they can pick it up and carry it into the restroom. And I tell them, if you don't think that you can manage the tubing and go into the bathroom, call me, call the tech. One of us will hold it and help you get to the bathroom, because I don't want them to come and be like, hey, here's my chest tube. That's bad news. And if they're going for a procedure, the chest tube goes with them. You never want to milk the tube or strip the tube. So sometimes you can see clots in there, or you see fluid that's just stuck there. You don't want to strip it or milk it. When you do this, it causes intrathoracic pressure, which can then cause damage to the lung and cause harm to the patient. Removal, always performed by a doctor. It's removed when the drainage is less than 100 ml per day. Current literature, evidence-based practice that we see is a little bit more aggressive. It cites that they can be removed when the output is less than 400 in the absence of any air leaks, but it's always going to be up to the doctor. They're going to let you know when they want to remove it. Care after removal, we want to monitor that site for any extra drainage. We shouldn't see any bleeding. We want to get an x-ray to make sure that the lung is still inflated. We're going to be watching those vital signs, so their heart rate, their oxygen, and then of course we want to watch their respiratory function. So you're going to assess the status of their respiratory system, oxygen, mental status, breath sounds. You're going to be watching that water seal for fluctuations of water when the patient breathes in and out. Assess any color and the amount of drainage, the patency of the tubes. Make sure you're checking that dressing during your shift, and you're going to check for any problems. So some nursing diagnoses. We might have ineffective breathing patterns related to asymmetrical lung expansion, could be caused secondary to pain. Impaired gas exchange related to decreased functional lung tissue. Acute pain related to presence of chest tubes or injury. Risk for injury, pressure of an invasion of the chest tube. And then fear related to they're scared for their own well-being because they have difficulty breathing. So teaching and health promotion, we want to educate them about mobility in the room with chest tubes. Usually, I've never seen a patient go home with a chest tube. I guess anything's possible. I've never seen that. So telling them to call for help, making sure that they have long enough tubes so that they can reach to go to the bathroom. Just because they're on a chest tube is not a reason for us to leave them in bed. We can safely hold their chest tube and get them to the bedside, to the chair, get them to the bathroom. We're going to make sure we're doing those respiratory exercises. And then if they have to follow up, if they need any community resources. Possible complications. The chest tube could come dislodged. This is a medical emergency. Notify the doctor immediately. If the chest tube doesn't work, you might have to do a tracheostomy. That would be severe. And then they could require mechanical ventilation. Hopefully the chest tube works. So now we have pulmonary emphysema. Let's see. So we're almost done. We're on slide 123. Let me see. We only have emphysema and tracheostomy. We only have to go to 137. We're on 123, and then we're done. So next week we can do a study session, or we can stop now and finish the rest of this next week and then do a study session after, or we can finish it now. What do you guys want to do? Don't everybody talk at once.
Now and
Finish
finish
sheets.
next week.
I say finish now so we have more time for a study session next week.
Yeah.
Yeah, finish.
Okay.
Who wants to finish now? Raise your hand. Okay. Most people are raising their hand. All right, let's just bust through it and then we will, we can do a study session next week for your test and then, yeah. All right, so pulmonary emphysema. So it is a chronic disease characterized by abnormal distension of the alveoli and those alveolar walls and the capillary beds. When you see them, they will, they show marked destruction. So the process of destruction occurs over a long period of time. This is not an acute illness. It's a chronic illness that occurs over a long period of time. It's the most common cause of disability and the most common obstructive lung disorder. So if you look at the picture here, this is your normal alveoli. The alveoli with emphysema are extremely damaged. They don't look anything the same. They're all deflated. You're definitely not getting good oxygenation in there. So pathophysiology, the alveolar walls are going to be broken down. They lose their elasticity. They form one large sac instead of multiple. Let's go back to that picture. Yep, see over here, multiple little alveoli. Over here, one large sac. It creates a small airspace and then it traps air that would normally be expired. You have fibrous tissue and destruction of the alveoli are going to prevent that exchange of oxygen and carbon dioxide during respiration. As the disease progresses, you're going to get bullae and blebs, which are large air sacs that can be seen over the lung surface. These sacs can rupture, and what happens is that once they rupture, they allow air into the thorax and you can have a pneumothorax. So risk factors are advanced age. So older clients have that decreased pulmonary reserve due to those normal lung changes that we see in advanced age, patients who smoke cigarettes, and then any environmental exposure. So air pollution, depending on what type of jobs they had in their lifetime, things like that, secondhand smoke, primary smoke. So signs and symptoms, you're going to see exertional dyspnea. So shortness of breath with minimal activity, just getting up, walking to the bed. They're going to be short of breath. As the disease progresses, the breathlessness even occurs at rest. Productive cough that is most severe upon rising in the morning, and it is going to be productive of mucopurulent sputum. So it's going to be yellow or green. It's really gross. Hypoxemia, so you're going to have decreased oxygen saturation levels. You're going to hear diminished lung sounds. You might hear wheezes or crackles. You are going to see clubbing of those fingers and toes. This is a late sign of disease. You're going to see a very rigid chest cage, and then you're going to have prolonged expiratory phase because all that air in there is trapped. They're going to be barrel chested. They're going to be breathing through pursed lips, and they're going to be using accessory muscles. So when you see them sitting on the end of the bed, they're going to be like, it's going to be very hard for them to talk to you. It's noticeable right away that they have emphysema. Through progression with unsuccessful treatment, they're going to show loss of sleep, appetite, they're going to show weight loss, and physical strength. They're going to lose their physical strength. This is an important slide. You guys need to know this. So there's a great example of a patient, a normal adult compared to the patient with barrel chest, and that is exactly what they look like. Their chest is characteristically barrel shaped. They use those accessory muscles in the jaw and the neck and those intercostal muscles. They have rapid, shallow respirations. The patient is going to appear drawn. They're going to be anxious because they can't breathe, and they're usually pale. They can have pallor and cyanosis of nail beds and their mucous membranes, and they typically speak in short, jerky sentences because they don't have the oxygen to hold a normal conversation. So when you talk to them and you say, Mrs. Jones, are you having any pain today? Yes, I have pain that's how they talk to you. When patients, they often lean forward. Remember, I told you that earlier. So they lean forward, they take their elbows, their arms are braced on their knees, they're supporting their chest and their shoulders because this helps them feel like they're breathing a little bit better. Advanced cases of emphysema, you're going to see memory loss, drowsiness, confusion, loss of judgment, lethargy, stupor, and then eventually coma, because they're going to have what's called carbon dioxide narcosis, because it's going to be the oxygen is going to greatly reduce that reaches the brain, and then we're going to see increased carbon dioxide in the blood, and it's going to cause all those symptoms. So diagnostic findings, we can do a chest x-ray, which is going to reveal hyperinflammation of the alveoli and a flattened diaphragm. We can do a fluoroscopy, which is also going to reveal hyperinflated lung fields because we have too much air in there. We're hyperinflated. Our laboratory test, we're going to see increased hematocrit level because our oxygenation level is decreased. So when that might be, I put it down here in the notes for you guys to refer back to. So oxygen in the blood, we know that it's carried by hemoglobin, which we measure hemoglobin by hematocrit. So when we have patients that have severe cases of obstructive lung disease, the body adjusts to that reduced amount of oxygen that reaches the blood from the lungs, producing more hemoglobin, which compensates for the failure in the lungs to transfer to that full amount of oxygen. So what we see is that increased hemoglobin in these patients, but it's related to the low levels of oxygen. So I put that in the notes for you. A CT scan also going to show hyperinflated lungs. We're going to have them on pulse oximetry, continuous or not. Oxygen levels are going to be less than 90%, maybe around 92, maybe 90, sometimes 89. They live there. Pulmonary function studies. So we're going to see a decrease in their overall function, their vital capacity, their forced expiratory volume. That increased total lung capacity because they're the amount of air that your lungs can hold, the lungs are overinflated. So their lung capacity is going to be increased. And then that residual volume because we're keeping air in. Our ABGs are going to show hypoxemia. So we're going to have that decreased PaO2. We're going to have respiratory acidosis. This is a respiratory issue. We're going to have excessive carbon dioxide in the blood. The lungs are not able to blow off carbon dioxide. And we're also going to see hypercarbia, which is increased carbon dioxide in our blood. Medical management. So our goal is going to be to improve the patient's quality of life and slow the disease progression, treat the obstructed airways. So we're going to use bronchodilators. Albuterol gives rapid relief. We're going to use those mucolytic agents to help thin secretions, make it easier for them to expel the secretions. Aerosol therapy, so those nebulizers for that deep inhalation of those bronchodilators, O2 therapy, but again, no more than 2 to 3 minutes because remember their drive to breathe requires lower oxygen. So we don't want to give them too much oxygen. So never any more than 3. If they have COPD, they should, 4 is pushing it. 3 is usually 2 to 3 is usually good for them. If you give them 4, 5, or 6, it's never going to improve their oxygenation status. It's going to make it harder for them to breathe. It's going to be toxic. Antibiotics, if they have some type of an infection, maybe a pneumonia or bronchitis. Physical therapy because they can't do their activities of daily living like they normally can because of their breathing. So they become very sedentary. We're going to use those inhaled corticosteroid drugs, oral corticosteroids. We want to help decrease that airway inflammation on a limited basis to assist with those removals of secretions. So I put in here in the notes about the respiratory drive is affected by our CO2 levels, so you guys can read more about that. Our nursing assessment, we're going to look for that dyspnea at rest or with exertion. They're going to have a chronic productive cough. They're going to have that pursed lip breathing. It's going to be hard for them to get fluid out because their lungs are easy to inflate. They're very difficult to deflate. It takes a lot longer to blow all that air out. So we're going to see carbon dioxide narcosis. And then we're going to see the use of those accessory muscles, and they're going to be barrel chested. Client education, we want to encourage the client to eat high caloric foods to promote energy. Remember, we said as this progression progresses that we are going to see that they kind of like start to waste away. They lose weight. We want to encourage rest periods as needed. They might need a lot of them because it doesn't take a lot to get them winded. Even at rest, they have shortness of breath. We want to promote good hand washing to prevent infection. We want to reinforce the importance of taking your medications. So your maintenance medications, your rescue inhalers, oral medications. If you smoke, they need to stop. You want to encourage them to get immunizations, right? This is the perfect person to get a flu shot and a pneumonia shot. We don't want to get a risk. We don't want to get them to get any type of an infection that can turn into pneumonia and further compromise their breathing. It could kill them. We want to encourage them to use their oxygen as prescribed. Inform other caregivers not to smoke around the patient because of the oxygen and it being flammable. We want to avoid dry, heated areas, which can aggravate their breathing symptoms. And then we want to humidify their air during the winter months. And then there is a nice a nice chart on your book, page 337, that goes all about client and family teaching. So nursing diagnosis, ineffective airway clearance related to bronchoconstriction, increased constriction, not construction. Increased mucus production, ineffective cough. You want to perform those postural draining with percussion, not us, because we don't do percussion. And then that vibration twice a day. Respiratory therapy can do this. Physical therapy can do this. Encourage effective coughing. We can help by suctioning to help remove those secretions. Position the patient so they have maximum ventilation, so that high Fowler's position. And we want to increase their fluid. Why do we want to increase their fluid?
Thin out the secretions.
Yes, very good. Very good. All right, so nursing diagnosis. We want to administer those bronchodilators. Either it could just be in their inhaler or by nebulizer. We want to encourage them to use diaphragmatic and pursed lip breathing. So take a breath in through your nose, out through your lips and mouth. Do not puff your cheeks. With exhalation, this is going to allow optimal exhalation of all that carbon dioxide. So we're going to see impaired gas exchange related to prolonged expirations and a loss of lung tissue and atelectasis. We're going to monitor the level of consciousness and mental status and monitor the results of ABGs. These are all your nursing diagnoses. I'm not going to read over these. You guys can read over these. And then we have tracheostomy. So this is our last exemplar. Our tracheostomy is a surgical opening in the trachea into which a tracheostomy or a laryngectomy tube is inserted. It can be temporary or permanent. It can be reversible. It can be used to replace an endotracheal tube or to provide for mechanical ventilation of the patient. Remember I said some patients that have to have prolonged mechanical ventilation, they can't stay on that ventilator, so we have to do that tracheostomy. Or sometimes we do it to bypass an upper airway obstruction or to remove tracheobronchial secretions. So the tube that we put in is made of a semi-flexible rigid plastic or sometimes metal. So it has to kind of conform to that area and be flexible enough. It's kind of like on an angle to go into that area. The tube does consist of an outer cannula, or some people call it the main shaft, and an inner cannula. And then they have an obturator. So you guys are going to be able to see all this when you go to lab this weekend, and then all this will start to make sense. Sometimes that inner cannula, it can be replaced or it has to be cleaned. So when we talk about that inner cannula as nurses, we have to look at that and take care of it and clean it every 4 hours when we have a patient that has a tracheostomy. Sometimes we can take it out and throw it away. It's disposable. Sometimes it's not. So you have to take your little scrubby brush and stick it in there and get all the phlegm. It's my favorite thing to do, the phlegm out of it. So nursing management. So we are going to monitor, you are going to frequently monitor their airway patency. This is your take home. My husband's locked out. My kids locked him out of the garage. I'm sorry, I gotta let him in. Hold on 1 second. I just don't understand why that happens. Frequent monitor airway patency. This is your take home of your trade. You need to monitor their patency of their airway. Make sure that they are breathing, they don't have any secretions. Monitor the airway patency. So you want to observe for any kind of complications. So aspiration, any kind of infection, pneumothorax, any type of airway obstruction. Sometimes a fistula can form between the trachea and the esophagus. Sometimes they can get what's called a mucus plug. They have a lot of secretions. Some people that have had it for a long time are very good about managing it and they can get them out. Some people die from mucus plugs. So the mucus gets so thick and it's exactly what I said. It's a plug. They can't get any oxygen in and they suffocate and they die. That's why we're assessing it every 4 hours in the hospital. We're taking it out and we're cleaning it because the mucus is so thick and it gets stuck in there and then no air can get in there. So you want to observe for any type of airway obstruction. You want to check to make sure they're not cyanotic. Are they restless, which could indicate a lack of oxygen? Do they have anxiety? Do they appear frightened? Is their pulse ox dropping? These are signs of airway obstruction. You want to make sure that you keep the client in a supine or a low Fowler's position. You want to make, when you're changing it and you're suctioning and things like that, it's just better to have them in that position. You want to observe if they have any tape that's holding it down. Usually it's not any tape. It's called a trach collar that has some Velcro on it. You always want to make sure that that is secure. You want to make sure that their hospital gown or their covers don't get pulled up over the opening and they can't get any air in. You are doing frequent suctioning to prevent any mucus plug from those copious secretions and cleaning out that area. You definitely want to have humidified oxygen for these patients because of the dry air. If your patient if you start suctioning and you're getting blood or blood-tinged sputum, then you want to make sure you have humidification. And then you want to keep a tracheal dilator at the bed at all times. I don't call it a tracheal dilator. I keep it, we just say that we need a size smaller than their inner cannula. We want an inner cannula that is a size smaller than what they wear, because if for some reason they decannulate themselves, and I've seen them do this, the whole thing just comes out. It doesn't take long, like seconds. And depending on how established it is, that hole is going to start to close right up. So the one that you have that they pulled out may not go back in. So you want to have one that's a size smaller. So in case they pull it out, you can put it back in. Let's see. Come on. Is that right? Okay, so some nursing diagnoses that we will see. Risk for ineffective airway clearance. So we're going to monitor vital sounds, breath sounds, skin color, level of consciousness, mental status, airway patency. Risk for infection. So you're going to monitor that stoma. Make sure, especially if it's a new one, that it's not red or it's not getting infected. We're doing routine tracheostomy care. So we're cleaning the inner cannula. We're checking the trach collar to make sure. Some people just ooze secretions all the time. So those trach collars get really disgusting, and you just have to change them every 4 hours. And then we put like some gauze underneath to keep the area from getting red. It's kind of like with the G-tube. If you have all those secretions coming out, it's going to sit on the skin and break that skin down, and then it's going to get infected. So you want to make sure you keep that area as clean as possible. Risk for ineffective management, humidified air, right, to keep it from getting crusty and bloody. You always want to prepare for emergency situations. So if you have a patient with a trach, you always want to order an emergency kit or a whole trach kit. You want to have everything you need. You want to have saline bullets to put in there if you have to suction. You want to have multiple suction tubes, lots of saline, any kind of an emergency kit you want to have. And you definitely want to have an inner cannula a size smaller than what the patient wears. You want to do tracheal suction as needed or as ordered to prevent secretions. And then you want to think some of these patients don't have a talk. I forgot where I was. They don't have a speaking valve and they can't talk. So you have to think about providing alternative ways to communicate with them. So you could give them a pen and paper. You could give them like a little whiteboard. Patients that have had these tracheostomies for a long time that can't communicate, they usually bring things into the hospital with them because they know that it's going to be an issue. So you just want to think about that. And when you suction a client with a tracheostomy, so you need to know how to suction a patient. You're going to see this on your test. And you're going to learn how to do it this Saturday at lab, and it's all going to make sense once you see it. So you're going to use sterile equipment. You're going to have sterile gloves, a suction catheter, and normal saline. It is an aseptic technique for tracheal suction. They're going to tell you in lab that it's sterile. It's not. When you go into the hospital setting, it's not a sterile procedure. So we always teach you what the book tells you, but we also want you to know how you're going to see it in the clinical setting, because some of these guys are going to see that. It's an aseptic technique. So you're going to put that patient in the Fowler's position. You're always going to make sure that you pre-oxygenate them beforehand, because after you pre-oxygenate them, you're going to remove that little bit of that oxygen to go down and suction them. So you want to make sure they have good oxygen for at least 1 to 2 minutes. You're going to check that your suction is on a low setting because you don't want to cause trauma and by having it at a medium or a high setting. You open your suction kit, usually at the side of the bed. You get your side table set up so that everything is right where you need it. You don your gloves. You lubricate your it's either going to be a 10 to a 14-inch French or a 14 French disposable catheter. You're going to fill your little box that you have with sterile saline. And then what you're going to do is you're going to insert the end of the suction into the tubing, and you're going to apply pressure with your thumb to the suction, and it's going to suck back water. That way you're testing the tube to make sure that it's working. This isn't going to make a lot of sense until you see it in lab. You never apply suction when the catheter is going down the trachea, because it's going to irritate the lining of the trachea. So you insert it down the trachea, you go until you meet resistance or the patient starts to cough. Then you move the catheter in a circular motion as you're pulling it back out of the lumen while you're applying intermittent pressure. So we don't ever just hold pressure with our thumb. We always tap it like this while we're circulating it and bringing it out. We don't want to suction more than 10 seconds at a time. You want to re-oxygenate them in between, give them periods to rest, and take a deep breath before you repeat it if suctioning is necessary. More often than not, usually you don't get it all at the first time. Usually it's 2 or 3 times. 3 times is usually the most I will do it. Sometimes you have patients that are used to managing their trach and they have certain ways that they do it. I always follow policy. If they want to do different, I let them do it. Usually 3 is my limit. And then you make sure you discard that catheter after use. We never ever reuse them, but you want to make sure you have a couple of them at the bedside. So you will have to know how to suction a client. You're going to see that on your test. And then when you go to lab this Saturday, that's all going to start to make sense to you once you actually see it, get your hands on the material, and you can actually practice. All right.